All right. Are we doing it?
I think that, if you look at the concept of insurance, insurance is for random, infrequent, and unpredictable events.
This is true. Having insurance for like drugs, like things that you're regularly paying for, is not a really like an insurance event. That's kind of weird. You can make some very libertarian-esque arguments with this, though. I don't know where this guy will go with it, but hold on.
Okay. And when the primary role of insurance was to prevent catastrophic loss if you had a heart attack or you had an accident or you had
cancer.
An appendicitis or you had a cancer, which back in those days was less of a chronic disease, the concept of insurance made some sense, right? Now, if you look at what drives expenditures from a health status standpoint, it's a lot of chronic illness. And in many cases, it's multiple chronic illness. We'll get into obesity, diabetes, heart disease, lung disease. Even, the innovation in HIV care in this country, AIDS has become a chronic disease. Cancer is becoming more of a chronic disease. We try to insure somewhat uninsurable events, right?
Is alimony common in the West? No, it's like 10% of marriages have any alimony agreement. It's pretty rare. This is true and is probably one of the better arguments against any type of insurance model, but more just like a subsidization model or a government, at the very least a public option model, is that it doesn't make sense to buy insurance for things that you're regularly charging against, because it's not insurance at that point. It's like something different. You're like paying into another payment plan.
You don't wake up every morning and think, I've got car insurance. Let me go figure out how to use my car insurance to get an oil change. But when we think about we're going to go to the doctor to get a preventative checkup or refill my regular diabetes medicine, which I'm going to be on for the rest of my life, we think insurance. But it's not really an insurable event. Insurance today is a discount card. It's not insurance in healthcare. Like insurance traditionally would be in other parts of your life where you procure insurance for random, infrequent, and unpredictable events.
Hey everyone, welcome to the Drive Podcast. I'm your host, Peter Attia. Sam, thank you so much for coming down to Austin to have this discussion.
I appreciate the opportunity.
Yeah, this is a conversation I've wanted to have for a long time, both for my edification, but also because I think it's such an important topic. And interestingly, for whatever reason, it waxes and wanes in public consciousness over time. There are periods of time when healthcare is on the forefront of everybody's mind, in some aspect, right? It can either be cost or quality or access. For what it's worth, at this moment, it seems to be dwarfed by other affairs, but that doesn't mean that it's not going to be front and center in 6 months or a year or whatever. And therefore, I think in many ways, this discussion today, my hope serves as the masterclass on the United States healthcare system. One other point I think I would make, just for the listeners to understand, is I fashion myself as a person who tends to get deep into things and then quickly come to an understanding of them. I have been rather unsuccessful in understanding healthcare. I'm sure my understanding is greater than the average person, but it still feels woefully inept relative to the effort I put into understanding it. So I'm personally just looking forward to how much more I'm going to understand this in a few hours than I do today.
Well, I'm sure with good questions, I'm going to learn a lot too. So I'm looking forward to it as well.
So we're going to talk about the things that people care about, right? Which is, why is it so expensive? Why isn't everybody covered? Why do we not have the best life expectancy? In fact, on average, why do we have horrible life expectancy despite spending twice as much as anybody else? But we can't have that discussion if people don't understand the system. And that gets to kind of what I just said a minute ago. It's a really complicated system. You're one of the most structured thinkers I know of. So I'm going to actually just defer to you as to what framework do you want to put to this for people to understand how so many trillions of dollars flow in, so many trillions of dollars flow out, who's paying, who's receiving, how is this thing organized, and why are we different than every other country on the planet?
Yeah, let's start with how the system works from a financing perspective. And then I think we can talk about how that's different than other countries. We can talk about the impact on outcomes, and we can probably even start to set up the framework on, as you say, the things people are interested in, why, and what can we do about it. But it's hard to start anywhere other than, this is now close to 20% of the U.S. economy, healthcare, 17, 18% currently. And
but let's give a number to that, because that is people don't understand how big the U.S. economy is. So how many dollars are we talking about?
Yeah, we're talking about a U.S. economy, gross domestic product, that's probably $28 trillion, okay?
That's 20% of the world, 20 to 25% of the world's economy.
With about 7%, right, or less of the, And another way to think about it, that's almost $90,000 per person in the U.S., okay? We spend $11,000 to $12,000 per person in the U.S. on total healthcare expenditure. Just to put that in context, $4 trillion of expenditure in the healthcare sector. If you added up all of the exports that the United States sends out across all industries, you're talking about $3 trillion. We import more than we export. We're a consumer culture. That's close to $4 trillion, but not quite at $4 trillion today. You just put that in context in terms of how much we spend in healthcare in the U.S. It's a huge number. And I appreciate the comments about, how healthcare as a topic waxes and wanes with respect to being top of mind. But any discussion about the economy, about inflation, about jobs, you're really talking about healthcare in many ways. It may not be as direct as talking about healthcare policy, but you're really talking about healthcare, given that it's almost 20% of the economy.
If the question is, should we have private or publicly funded insurance, you change that question to how should we fund the healthcare? There's like a lot of healthcare is just a very complicated thing. But nobody is capable of having like the conversation topics are all retarded. Like people think it's expensive just because of greedy CEOs or whatever insurance companies, half the people in here apparently think. Other people mistakenly assume that if we just did universal healthcare, or if we did universal healthcare coverage or something like that in the United States, that our quality would remain the exact same. And that the price would just decrease for everybody. That's probably not true. My guess is the quality would probably drop in a few areas, maybe increase in other areas. But the idea that like we just have enough healthcare to give to everybody for as much as they want with absolutely no drawbacks is just kind of a delusional way of approaching healthcare. But
and there's no escaping that.
Do we know that it represents roughly 20% of the workforce as well?
Well, it probably represents.
But I do think there are really good market. There's good market arguments for why healthcare is not. It's just not a very. It's not a very good when it comes to like market choices, right? So if you think about ways you generally shop for a product, usually you're doing a cost benefit analysis, you're comparing like one product with another. Oftentimes when you need to consume healthcare, like in an emergency event, you don't have time to make those comparisons. The goods themselves or the services are also generally really inelastic. They might be very complicated, difficult to understand. There's like a lot of reasons why healthcare might not be the best like good or service to offer on an open market because a consumer's ability to make decisions about healthcare can be compromised in a few ways, depending on what type of healthcare consumption you're talking about.
Being that.
Do we know that it represents roughly 20% of the workforce as well?
Well, it probably represents, in terms of wages, a little bit more than.
Lemeo, he thinks U.S. healthcare is better because of overpricing. I don't know what country you live in, but I guarantee you that none of our famous and rich people go to your dog shit country for hospitals, and I bet that some people from your country come to our hospitals for healthcare. So suck my dick, Eurocuck.
Because the average wage in healthcare is higher than in other areas, and this is something that.
Do we know that it represents
inflation, about jobs? You're really talking about healthcare in many ways. It may not be as direct as talking about healthcare policy, but you're really talking about healthcare, given that it's almost 20% of the economy, and there's no escaping that.
Do we know that it represents roughly 20% of the workforce as well?
Well, it probably represents, in terms of wages, a little bit more than that, because the average wage in healthcare is higher than in other areas. And this is something that, as we get into how you think about the future, we should talk about, because as healthcare as a percentage of the U.S. economy grows, you can't have that happen without considering what it does to the rest of the economy. And that's going to be an important discussion around U.S. competitiveness, U.S. affordability, U.S. coverage, et cetera, given the nature of healthcare and healthcare issues today. So
do you think it makes sense, and feel free to shoot this idea down, does it make sense to go back to the 1950s to start with Hilburton, to start with, and then progress into Medicare and Medicaid? Like,
Just food and water are inelastic as a need? Yes, food and water are very inelastic. But you're typically not making decisions on whether to buy food or water at the point of starvation or thirst to death or dehydration. And you typically markets solve a lot better for delivery of food and water. There's tons of different types of water you can get. There's tons of different types of food you can get. We have, for water itself, we have like public municipalities that deliver water to homes. Like
historical context, give people a sense of like what happened after World War II.
Yeah,
what did the United
let's
States
do that,
look like?
because I think and we can do it quickly and give people a sense of what happened. But let's just start with painting the picture of where we are today, and then let's back up and say, how did we get here? Okay, so $4 trillion, and again, just to keep this simple, about $1 trillion of that, okay, 1/4, comes from consumers. Now, some of that is spent in, you and I both would contribute to the insurance we procure, and some of that we're directly consuming healthcare by spending money on healthcare services out of our pockets. But think about it as 1/4 or $1 trillion. Employers put another $1 trillion into the system. So how do they do that? Largely through employer-sponsored insurance. So that's the second $1 trillion. So now you've accounted only for half of it. So where's the other half coming from? The other half is coming from government, federal government and state government. These days, a lot of it is federal government. And the federal government contributes in two different ways: direct expenditures, and as we'll get into when we start talking about history, employer-sponsored coverage being the dominant source of coverage is unique to the United States.
Which just seems like a horrible idea. And it seems like it did so many bad things for...
Right, which is that your employer procures health insurance for employees, which then provides a form of coverage. That's relatively unique as a mechanism of coverage. And let's make sure that
people appreciate that, because someone listening to this might say, but I have a health insurance card and it says Blue Shield on it. So doesn't Blue Shield provide my insurance?
That's correct, but it's coming through your employer, and most people would recognize that because of their annual enrollment, right? So they're picking Blue Shield or Aetna or Cigna or United, or if they're in a Medicare plan, they may be looking at Humana or other Blues plans from that standpoint.
But the point is that the Humana, the Aetna, the whoever is on the card is usually providing an administrative service only if the employer is large enough that the employer is bearing the risk. Which we'll get into that. Maybe you should explain that a little more.
Yeah.
Okay.
So you've got 1/4 that people are spending out of pocket in one form or another. Some of it, of course, to subsidize their ability to buy insurance. 1/4 that's coming from employers directly, right out of their profits. Now think about that $1 trillion for 1 second. Total U.S. corporate profits are about, interestingly, coincidentally, just south of $4 trillion.
Really?
So corporate profits, okay, post-tax. So the expenditure in healthcare is pretty significant, right? When you think about it that way. Now, off of total revenues, of course, it's a lot lower as a percentage. But if you think about it from the perspective of total corporate profits, that's a big number.
I don't know why we would just look at profits, not revenues. The revenue figure would be much, much, much higher, but okay. That's an odd point of comparison.
The U.S. consumer spends, you should think of it this way, for that $1 trillion, it's about, if you have a $20 bill, $1 of that is going into direct healthcare expenditure, like 5% of someone's expenditure in an annual average basis. Okay, and then you've got the government. The government's spending about $2 trillion. Again, it's direct spend, plus there's tax subsidy for employer-sponsored insurance. We'll get into that because that's a unique feature. When you talk about 1950s, 1954, the tax benefits for providing employer-sponsored insurance were codified into law.
By the way, going back to that $1 trillion that employers are spending, that is a pre-tax benefit basically to employees.
And that's the incentive. And that's the incentive that
fuck, I'm so sorry. Never mind. This is just what's being spent by employers. Never mind. That it makes more sense why he would compare that now. My bad.
started back in 1954, which is that giving people healthcare coverage through group purchased insurance by your employer is a pre-tax benefit rather than a post-tax benefit. So it created an incentive for employer-sponsored insurance to grow and now, of course, ultimately become the dominant form of which people procure insurance today outside of government.
What's the approximate cutoff in company size at which point it makes sense to self-insure, which is what you're describing?
Oh, I think to your point, it's mostly larger companies that do that. But, the definition of large isn't that large. I mean,
it's 50 to 100 employees must be large. Is it 50?
Or entities.
500 people?
Yeah, there are entities with
500? I feel like 100 plus is a pretty large company, no?
less than 500 employees that self-insure at times. Not that common, but certainly as you get above that level, it makes sense.
Okay.
Now, let's for a second put the federal spending
Maybe not 50, 100, 500, damn.
in context, right? I mean, close to with the direct and the tax in-kind contribution to healthcare that the federal government is making, you're getting close to $2 trillion, $1.8, $2 trillion. Defense spending, let's just put that in context. That's about $1 trillion. Social Security, $1.2 trillion.
And to be clear, Social Security doesn't come out of tax revenue directly.
That's correct.
That's prepaid. The number that I keep thinking of, Sam, is the government collects $5 trillion a year in taxes. That's the government's income is $5 trillion, and we're putting 40% of that right back into healthcare, if I'm understanding this correctly?
Well, yeah, I mean, we that may be what we collect, but obviously the government is spending closer to 6.8 trillion or something like that.
That's right. There's a trade deficit.
Yeah,
There's a deficit.
Yeah.
So this is the other thing that we were talking about the other day that just blows my mind, which is we collect $5 trillion a year. We spend $7 trillion a year. So we have a deficit of $2 trillion a year in perpetuity. Oh, and by the way, we're sitting on $35 trillion of debt.
Total debt.
We're going to come back to this point in a minute. I'm going to borrow from Paul Tudor Jones on his very eloquent explanation for how do you put that in context.
Yeah. No, and ultimately that is, I think, the question when healthcare is such a large part of the economy, how sustainable is it what we're doing in healthcare expenditure? So, look, you take all that money and financing, and then in the US, there's a system that it goes into, right? You got $4 trillion, a quarter, and half from government, and you're flowing it into a system. And in our system, about $2.5 trillion of that, plus some from the government, is flowing into private insurance, okay? They're covering, what we would traditionally call commercial insurance, but the private insurance community is also covering a bit of Medicare and Medicaid, increasingly large proportions of that.
That's through programs like Medicare Advantage and things like that.
Or Managed Medicaid or other things like that, that allow for, theoretically, better choice, better benefits, and other things, and maybe even cost control. And then there is a retail component. And then obviously the government does pay directly to providers through Medicare and Medicaid some amount of money, and that's about $1 trillion. So the split and flow, you can break it down pretty simply from that perspective. Look, when I look at how the money's spent in a way that people can understand, I think of very simple rules. We'll get into this, which is administrative cost in the US is probably one of the biggest gaps to what we see in the rest of the world. And that can be good or bad. You have to make a judgment about whether all that administrative spend is creating a better system with more choice and better outcomes or not. But we do spend that. And that takes up, close to 10 to 15% of the total pool of dollars. When you think about that number on $4 trillion, that's a huge amount of money going into administration. We'll talk about that. For the remaining dollars, look, about a third goes into hospitals, about a third goes into hospitals and infrastructure-based care, about a third goes into physicians' offices and other clinic-type activities, and about a third goes into drugs. Again, simplification from that perspective. In the drug, and I would add to that maybe drug and device.
Wait, did he just list 4/3? Wait.
And about a third goes to hospitals and infrastructure-based care. About a third goes into hospitals. About a third goes into hospitals and infrastructure-based care. About a third goes into physicians' offices and other clinic-type activities, and about a third goes into drugs. Again, simplification.
Oh, were the first two like the same? And then okay.
From that perspective. In the drug, and I would add to that maybe drug and device category, I'm including the cost of pharmaceuticals that might be administered in a doctor's office or a hospital, right? So just think about it as a third. And that's how people can think about it. When I go spend my money or I go into the healthcare system and I'm spending money, on average, a third is happening there. Obviously, some people never end up in the hospital. Many, small proportion of people end up costing us a lot in hospitals, for example. Some people are not on any drugs. Some people may be on 5 or 6 drugs. The system has a variety of what I call cross subsidies in it.
And just so that folks who are maybe thinking about other ways that they've heard this, because I know you've described it this way, which is it's often presented as half of the healthcare dollars are flowing into the facilities, one third of
How important are the niceties of U.S. healthcare? No wait, cutting edge tech. Oh, no wait time, cutting edge tech, top hospitals. If the health outcomes aren't better than other advanced countries and the costs are higher, shouldn't you focus on cost and outcomes? I mean, it's patient choice. I mean, like we like choice in the United States. It's a really big thing that patients like. I feel like there was I don't have a link to this anecdotally. I feel like there are certain drugs, so like for Vyvanse and like Adderall XR and stuff, like I feel like these were available earlier in the US and commonly prescribed, like way more than they were. Like it took a long time for European countries to start prescribing these as commonly, and that they would be using older drugs that just, as American patients, we just prefer to get like the newest shit, the best shit, like, and there's a bit of a premium that you pay for that. But
is going into payroll and physicians, and then 1/6 is going into drugs.
That's right.
But what the problem with that view, and the reason I like your 1/3 better, is it's more transparent, which is in the previous world where we say half goes into the facilities, we're discounting how much of that contains physician salary and how much of that also contains pharma. So when you strip that out, it's actually more elegant to point out it's 1/3.
The delivery industry is a pass-through to other things in some ways, right? And the 3-2-1 framework was probably an older framework. I mean, if you look at the rise of the total drug costs, which I'm sure we'll get into, the third is absolutely a more transparent and simplified way of looking at how we're spending our dollars.
Yeah. Okay, so that's where we are today. Let's go back. It's 1950. What someone comes home, it's late 40s, early 50s.
Yeah.
The U.S. is on top of the world. We're the great.
Destiny, this also goes the other way. The Ozempic was in Europe before the USA. Do you think if Europe started making better drugs, you guys would change your mind? Was Ozempic in Europe before the USA prescribed for for weight loss? I thought that Ozempic was initially a drug for something else. I forget what it was. Was it just diabetes or something? Was Ozempic being prescribed for weight loss in Europe before being prescribed for weight loss in the United States, or?
Greatest country in the world. Our GDP as a percentage of global GDP has never been higher and may never be higher again. In fact, even today, by the way, I just looked this up because I was so interested.
Yeah.
If you look at the percentage of global GDP that is the U.S.'s today, it's, quote, only 20 to 25%, which is still staggering. It was close to 40% post-World War II. Right. So what's happened over the last 20 years?
What's your day one policy on healthcare if it was you, and considering what you know? My day one policy would probably be a public option, at least, would be my guess.
Is China's GDP has expanded so much that as much as we continue to grow, our relative share has gone down. So we are economically, we've never been more dominant than we were post-World War II. What is true of healthcare? How does a person take care of themselves?
Yeah, and the one piece of context I would add to that introduction is that at the same time, the U.S. economy has grown robustly since then.
Yep.
So proportionally,
it's amazing.
Exactly, and I think that's an important factor in affordability, which is had the U.S. economy stagnated and others grown, this affordability question would be a very different question than what we've seen happen, which is the U.S. economy has grown incredibly robustly. But if you go back to the 1950s, and by the way, this is a global phenomenon, in and around the late 40s and let's say into the late 1950s, in many places, significant investments in social welfare programs and healthcare were made. So we'll talk about the U.S., but just as context, the NHS in the U.S.
Explain what a public option means. I think the idea to always have like a government, basically a government insurance plan that you can buy into that covers basically everything or most things, I guess. I don't know what right? Basically, right? So public option would be kind of like would this be, also you have to force every single person in the U.S. to buy into it. You have to force everybody to buy something. The ACA mandate needs to come back, where there's a fine for not buying into healthcare. But basically, I guess like Medicare available for all ages.
Okay, was created in 1948. Okay, so the systems that were designed to increase coverage originated in that time frame, roughly. Now, for us, it was 1965 when Medicare and Medicaid, came into being, but it was somewhere in that range. So you go back to the 1950s. I mean, first of all, we were spending less than 5% of GDP.
When did the mandate go away? Kind of under Trump when he first came into office, they got rid of the mandate for it. They wanted to pull the everything about it, but they only got rid of the mandate purchase part, basically.
On healthcare. Okay. I mean, as again, put that in context versus 17 and a half.
Yeah, we're almost 20 at this point.
Almost 20 from that perspective. More than half of those dollars were spent out of pocket, meaning you went to the doctor.
Which is today
and you paid your bill.
25%.
Which is today 25%. And actually, if you look at direct expenditures, where some of the dollars that you're putting in
are going to
cover your insurance premium, it's really 15%. So your direct exposure, what you see and feel in terms of what you're spending on healthcare, is down to 15%. That's important because the socialization of coverage, of costs, has made the American consumer less sensitive to the price points that they're seeing for everything, for drugs, for doctor's offices, for hospitalizations, et cetera. The other thing that's interesting is today, that means 85% of healthcare expenditures are covered by a third party, right? Whereas it used to be about 50%. So again, that sensitization phenomenon is real. The federal government contributed about, say, 12.5% to expenditures back then. Today, it's north of 35%, right? I mean, we've already been through that. When you add up direct spend plus tax benefits and other things that, lost taxes for the federal government, et cetera, when you look at that, you're about a third of the expenditure being the federal government. So the rise of the federal government's role in healthcare has been material and almost as rapid as the rise in healthcare costs.
What about multi-million-dollar bonuses for insurance executives no matter how the company did that year? My guess is that it's probably a rounding error to account for like every single CEO wage combined when you look at the total revenues and costs of all of these companies. The fixation and the obsession with fucking executive compensation and shit is such a loser fuck talking point and guarantees that you will never fix any of these issues.
From that perspective. So it's a very different system of consumption. Now, you could ask why.
Yeah, I was just about to say, do we have a sense historically why, as the NHS is coming into its existence in the UK, and as most developed nations are developing systems that look far more like the NHS than what we've done, was there something about our geography being much more vast than, say, England was in the 1940s that led itself to this? Was it this nature of the states' rights versus federal power? Like, what was the difference?
Yeah,
Would healthcare innovation exist if every country was single-payer healthcare? I feel like a lot of these single-payer country systems only work because you can go abroad and get the good shit and the knowledge is being transferred from the private shit. I would have to find it, but I thought I read like several years ago, like 5+ years ago, that the argument that the United States innovates more in healthcare than like Europe is not true. I thought that wasn't factually backed up, or that like the research in Europe had caught up. I could be wrong on that, but I'm not sure. But I don't know if the drug prices or if the overall healthcare costs in the United States necessarily means that we're getting better like R&D for it. I don't know if that's true.
I think there are all kinds of things in the ecosystem, including geographic diversity, state versus federal rights, and even fundamentally the drive that the American consumer has in determining their own outcome. And if you look at our system today, much of its construct is based on a desire for consumer choice. Mm-hmm. Okay, many of these programs, these coverage programs, or some would say welfare programs that evolved, like Medicare and Medicaid, were designed to solve some substantial problem. So if you go back, what happened at that time? Two things happened in the 1950s. One was there was a significant commitment to investment in hospital capacity. But
doesn't the salary issue point to a bigger problem, not of cost, but of what a person is willing to do, cut life-saving options to earn millions? Sure. Yeah.
The time. I mean, there were people in America, not just rural, but suburban, that did not have easy access to acute hospitalization. And the technology and ability to intervene and save lives in that setting was improving significantly. And I think at the time, there was a belief that it wasn't fair or equitable that access wouldn't exist. That's called the Hill-Burton Act. You referred to it earlier, which, if I think about it in simple terms, it guaranteed a hospital within every
10 miles or
10 or 15 miles of every American in concept, right? And that's what happened. And that legislation drove our thinking in terms of access, all the way until it expired in close to 2000, 1997, if I recall, from that perspective. So we made a massive investment in infrastructure from that perspective to provide people access. Okay, and that's important. The second thing that happened, of course, is that by the time you were in the 1960s, there really wasn't a coverage mechanism for seniors. I mean, there was patchwork stuff, and there wasn't really a coverage mechanism for those with less means, what we today call Medicaid. And it got to the point, especially with the importance of the seniors' power, not only of the purse, but from a political standpoint, where on average, seniors were spending a quarter of their retirement income from Social Security on healthcare. That wasn't sustainable. So they neither had consistent coverage, it was inequitable, and on average, a quarter of the Social Security check was being spent on healthcare. And so why Medicare and ultimately Medicaid associated with it was you had a country whose economy was growing rapidly. We could afford to take care of our seniors, and that was the decision at the time. It was met with great support, right? Obviously, at the time. And so you created a system in which that coverage existed, and therefore the federal government's expenditure jumped up significantly.
Now, why did we not do with Medicare what was done with Social Security? In other words, my understanding, which again, I'm embarrassed to say how little I understand this, but my understanding is Social Security is funded directly. It is not a budget line item. So that when I pay my Social Security on my paycheck, it's directly going to pay somebody, correct? It's not like building up a war chest that the government has to use to be paying down in the future. But Medicare works not the way Social Security does. But I still make a Medicare payment every month. So in other words, why haven't we at least been able to eliminate the challenge of Medicare and make it more like Social Security?
Yeah, well, we do pay Medicare taxes today, right? I mean, now there are special taxes to help fund Medicare, but it's really
the problem is then
it's a solvency issue.
Well, then it's a fungibility issue as well. You can use the Medicare tax to do something else.
Absolutely. And hindsight's 100% clear. If you think about when the legislation was put in, I said 1950, we were like 4.5% of GDP in healthcare. At the time Medicare came about in 1965, that number was in the mid to upper sixes, okay, at best. So who would have guessed that it would have risen to 17, 18, potentially in the future, 20%? I think well-intended, the U.S. healthcare system in many ways is a story, an optimistic story of well-intended policies that now are questioned based upon the way the expenditures have increased. There's another thing that's important to understand, which is as the U.S. healthcare expenditures increased as a percent of GDP, so did the rest of the developed world, right? So every developed nation that put in place programs, their version of Medicare or Medicaid, I understand more state-run than privately run.
My boomer dad always talks about ye old healthcare where stuff was cheaper, the doctor would come to the house, etc. Why was there such a dramatic increase in the cost of healthcare over the past 60, 70 years? I mean, in ye old healthcare, the doctor would come to your fucking home and rub Valium on your children's gums if they were crying too much. And if you were 60 and you fell and you broke your leg, they would just take you out back and shoot you. So, I mean, if you want to go back to that standard of healthcare, it's still available to you. I mean, like, you can get like the shittiest healthcare with the shittiest drugs and the shittiest surgeries and the shittiest, like that's available to you if you want it, but nobody wants those outcomes.
Their expenditures increased, right? They started like us in the 4s, and they've landed in the 11 to 12% range. We've just accelerated up to 17, 18%. Think about it this way. From that time forward, the U.S. economy relative to the healthcare economy has grown roughly 2% per year faster than the U.S. economy.
Yeah.
And the U.S. economy has grown robustly, better than the rest of the world. And so that's why the expenditures have gotten so high. And there have been periods where that's been slower, and there have been periods where that's been faster. Every time there's a new coverage event, Medicare or Medicaid, you know, some of what happened with the Medicare Modernization Act in 2000, we'll get into that when we talk about drug costs. And then obviously the Affordable Care Act, which created significantly more coverage, that rate of increase for healthcare expenditures relative to GDP growth has widened.
Let's maybe we're taking some things for granted here. Just tell people what CMS is, what Medicare and Medicaid actually do. Who do they cover? How do they
Sure.
Yep.
Yeah. Well, CMS, Center for Medicare and Medicaid Services, as it's called, Medicare covers people over the age of 65 and a bunch of special categories of people with severe chronic illness, take dialysis as an example, that it might be hard to find coverage on the private market over a long period of time given their needs. Okay, so it is more than what I would describe as a safety net program. It's a coverage program for people over the age of 65.
And how long does one have to have paid into it to qualify for it?
Everybody qualifies for Medicare at the age of 65.
It's not like Social Security.
It's not like Social Security. The benefit doesn't vary.
Anyone who is a U.S. citizen will qualify.
That's right.
Regardless.
And so Medicare, another interesting piece of context, think about life expectancy, right? I mean, we're going to get into life expectancy differences in the U.S. I mean, the fact is...
What was life expectancy in 1965?
I don't know what the exact number was in 1950 or 65. It wasn't what it is today, right? And the other thing you would say is that, look, I think you would agree, over the last 100 years, in the broad context and scheme of things, life expectancy in the developed world has improved remarkably.
It's about
remarkably.
2x.
2x. And yes, there are now differences at the top of the spectrum between the U.S. and others, which we'll get into. But this is in the context of a very, very rapid improvement in overall life expectancy. Health status may be a different thing, and I think that's also something...
Healthcare expenditures at end of life are also dramatically higher now as well, because you extend people's life more with really expensive and costly surgeries, and there are more older people. I think it's a proportion of the population than there were in the 50s and 60s too. So
now to talk about what really drove...
And Medicaid, just to round that out.
So Medicaid, let's give it. Medicaid is a safety net program, right? It is a program designed for individuals below different definitions, state by state, of certain measures of federal poverty level. And the idea behind the coverage is that for those people, not only are their needs unique, but their ability to access healthcare services can be challenged. And the benefit of having programs like Medicaid is it increases, I won't say it makes it entirely equitable, it increases their ability to access the healthcare system in a reasonable manner with a coverage system that avoids taking those least fortunate down a path of severe medical debt that would be overwhelming to their personal financial situation. That's how I think of Medicaid.
Do you have a ballpark sense of where those cutoffs are? Like in California, for example?
Yeah, I mean, the cutoffs range, somewhere between 100 and 200% plus of federal poverty level. And we'll get into maybe with the Affordable Care Act, the exchanges and whatnot, but they're, Medicaid covers a lot of people, okay? If you think about this, it now today covers 90 million people in the U.S.,
Jesus.
more than Medicare.
Medicaid covers 90
million people today in the U.S. Some states, almost a third of those covered, think Rust Belt states, are Medicaid today. So this is a very large program. Medicare covers probably, I would guess, 65 million or so today, and growing, right? As the population ages, we forecast that 65 million will become close to 90 million at the peak of the baby boomer aging, which is around 2032. In terms of time frame. But Medicaid today covers about 90 million people. That's a big number.
What is the federal poverty level today?
I don't know. Yeah, we can look that up in terms. I can tell you that the income level that defines federal poverty is pretty low. You or I would not consider that to be a reasonable living wage or income for a family in this environment with the cost of goods being what they are today.
Yeah, in other words, there are people who will not meet the criteria for poverty who maybe should based on purchasing power.
And who will be underinsured. And that's where things like the exchanges from the Affordable Care Act have stepped in to provide at least options for additional coverage so that people's healthcare costs can be offset. So, okay, that's helped bring me back to Medicare and Medicaid. So if you really look at, you have these programs that came into place. So what drove the rapid expansion? Because like another view of the world would have been that you had this coverage, the healthcare system stood still, and maybe the costs increased, but they didn't increase beyond 6, 7, 8% of GDP.
Now, let me ask you a question. I'm sorry to interrupt you, and you can tell me to just punt this and come back to it. I want to go back to the 1960s.
Yeah.
We go to the great lengths to create Medicare and Medicaid. Mm-hmm. Why did we not at that moment say, hey, why don't we just roll this out for everybody, just as the NHS has done?
Yeah.
Why did we instead continue to keep two completely different worlds, which is we have a government-funded system for people of low socioeconomic status. We have a government-funded system for people over 65 or with very chronic conditions. But for everybody else, we're going to do this crazy thing where your employer takes care of you. What was that decision?
Well, I think the employer-sponsored insurance system was already entrenched, right? Because of the tax benefits that existed.
So that was a decade earlier.
That is right.
I see.
And so that was entrenched. And why does that matter, right? I think this is an important point about our belief in consumerism and choice. The marketplace provides choice in a way that many of the nationalized healthcare systems that exist in other countries don't. Okay. And if you really look at many of those other countries, while they have a nationalized healthcare system that purportedly has universal coverage, they also have a private system, no differently than ours, where people with more means can procure better insurance and better access and a private healthcare system, et cetera. It's just not as widespread as it is here. In this country, there was a belief that was institutionalized by incentives that employer-sponsored insurance was working. And remember, at that time, it wasn't that expensive, okay? Meaning employers often covered 100% of the premium. So the employee did not end up having to contribute like they do today to the cost of their insurance as an employee that they're receiving from their employer. And that's, again, it was a comfortable system, if you imagine, at the time. And based upon the system, you got choice, right? Which product do I want? What kind of network do I want, et cetera? What happened as a result of that expanding, especially employer-sponsored insurance expanding, is that insurance moved from being an individual product based upon your or my individual risk to group insurance, right? What are you doing with employer-sponsored insurance? You're aggregating all the employees and all their risk, and you're socializing that risk among the whole group and saying, look, in order to protect each of you individually, we're going to share the risk as a group. We're going to buy the insurance collectively, and it'll spread the risk among us to avoid individual catastrophic loss from a healthcare perspective, expenditure perspective, right? That's what we did. We socialized in group insurance. That was a big move in the insurance industry as employer-sponsored insurance took off. Of course, Medicare, the concept of Medicare itself, by bringing all seniors together, was also socialization of healthcare costs across all seniors. Not all seniors spend equivalently, as you can imagine. So that was one. What happened on the other side is absolutely a story of incredible innovation over the last 50 to 75 years in healthcare, okay? And we can all debate what's resulted from that, but development and maturity of the pharmaceutical industry, development and maturity of the medical device industry, innovation in procedures and services that have allowed people to have invasive procedures in manners that used to hospitalize people for 3 weeks, and now it could be 3 days. And in some cases, if you're having a knee or hip replaced, it's at best 3 hours in and out the door, is amazing, right? And yet,
3-hour hip replacement? Wait, is that true? What would that be? Outpatient hip replacement? Wait, what? When severe hip pain doesn't respond to medication, lifestyle change, total hip replacement surgery can be an effective option for lasting relief based on your current activity. We recommend either inpatient or outpatient hip surgery. These advanced procedures allow patients to go home in as little as 24 hours after surgery. Holy fuck. Okay. Jesus. Average cost inpatient, or I'm sorry. Outpatient hip replacement surgery. $30,000 to $45,000. Inpatient hip replacement surgery.
Greetings, Dr. Hadzik here. This video is sponsored by Nysora's Neurobiological Hip Replacement Surgery, as well as our setup in Nysora, where we do over 1,000 hip replacements annually. And if you are one patient who is having hip replacement surgery, hip replacement is a major procedure which, when done well in a busy hip replacement center, it results in a substantial increase in the quality of life. The survey of our patients indicate that more than 95% of patients are happy with the hip replacement procedure. In our center, all of our patients are preconditioned and prepared for the hip replacement surgery. They are assigned a hip coach who builds their confidence, provides guidance.
Jesus Christ. Okay, I didn't know that. My God. Hold on, let me use the restroom for 1 second. By restroom, I'm gonna go grab a quick new hip. I feel like this is like Christmas music.
The impact of that, along with the socialization of healthcare costs, and therefore removing the individual from understanding or feeling that cost directly because they're insured, together was a virtuous cycle that just drove up consumption, right? I'm not an economist, but people would look at this and say, okay, there's moral hazard and concepts like that exist with an insurance system like that. And we should spend a minute on, what was insurance designed for back then and what is it now, right?
Yeah, I loved your analogy there. I've told this story before on the podcast, but assuming someone's listening who hasn't heard it, it's a great example. So I had a friend who is American, but he lived and worked most of the year in Riyadh, in Saudi Arabia. And I was out visiting him in Saudi Arabia. This is 15 years ago. And we're at his flat, and it was in the spring, and he was just kind of getting ready to head back to DC where he lived. And so I said to him, God, I can only imagine how hot it gets in Riyadh in the summer. So if you leave here in May, you come back in September, how hot is your apartment when you get back? Just out of curiosity.
Right.
Like, we're talking like, is it, a sauna? And he goes, no, 70 degrees. I'm like, what do you mean? He goes, I leave the air conditioning on the whole summer. I'm like, you leave your house and leave the air conditioning on for 4 months?
Jesus.
He goes, yeah. I go, that's crazy. He goes, I'm not paying for it.
Right.
Like, the government subsidizes all of our energy costs here. I pay the equivalent of a few cents per, whatever it is. Like, it was,
right.
He pays a few dollars over the summer to air condition his place. This is the exact point. When you don't have skin in the game, you can't make rational economic decisions.
Yeah, and I think, if you
Or
look
I shouldn't say that. It's a rational economic decision for him, but you can't make decisions that are wise in the context of resources.
Yeah. And I think that, if you look at the concept of insurance, insurance is for random, infrequent, and unpredictable events, okay? And when the primary role of insurance was to prevent catastrophic loss, if you had a heart attack or you had an accident or you had
cancer.
an appendicitis or you had a cancer, which back in those days was less of a chronic disease, the concept of insurance made some sense, right? Now, if you look at what drives expenditures from a health status standpoint, it's a lot of chronic illness. And in many cases, it's multiple chronic illness. We'll get into obesity, diabetes, heart disease, lung disease. Even, the innovation in HIV care in this country, AIDS has become a chronic disease. Cancer is becoming more of a chronic disease. We try to insure somewhat uninsurable events, right? You don't wake up every morning and think, oh, I've got car insurance. Let me go figure out how to use my car insurance to get an oil change. But when we think about we're going to go to the doctor to get a preventative checkup or refill my regular diabetes medicine, which I'm going to be on for the rest of my life, we think insurance. But it's not really an insurable event. Insurance today is a discount card. It's not insurance in healthcare. Like insurance traditionally would be in other parts of your life where you procure insurance for random, infrequent, and unpredictable events.
Is this manifested in the financials? So if you look at the insurance companies and you strip out their ASO business, that's the part I referenced earlier about the administrative part where they administer insurance to the employers. But if you look at the part of their book of business where they bear the risk,
yes,
do they look like Travelers? Do they look like Geico? Do they look like the types of companies that Warren Buffett is obsessed with because of float? Or do they just totally function different from a...
No, they function differently from that perspective. Obviously they have a tremendous amount of expertise in managing risk, but the nature of that risk they understand isn't random, infrequent, and unpredictable events.
It's not car insurance. It's
Absolutely.
not life. It's not life. It's not death. It's not disability.
That's right. The fundamental understanding that the insurance companies have to be successful in their risk business is understanding their risk pool. Right? So you're going to have 1,000 people in insurance. 5% may cost you 50% of your total spend. 20%, maybe 85% of your total spend. And then you'll have a large group of people that really on a unit basis don't spend very much. And they have to understand that risk pool.
If you and I wanted to start an insurance company tomorrow, I'm going to hang up everything I'm doing. You're going to hang up everything we're doing. We're going to go start the Peter Somm Insurance Company where we take risk.
Yep.
We don't have an ASO business. What would it take for us to be successful?
It's very hard because the number one thing that would create the foundation beyond all of the infrastructure and systems and other things required to function in a complex ecosystem
is the data, an algorithm, an AI. He's going to say something totally not.
Would be a large enough population of patients with a risk pool that you can understand.
Oh, okay. Never mind the people. Fuck.
And, look at all of the folks who have gotten into the newest exchange products that offered an opportunity to do that are the exchanges that have come out of the Affordable Care Act. And there have been, insurance companies that have popped up and have failed, and there have been some that have struggled but still exist. And there have been
kind of data. No. You need the bigger risk pools in order to charge lower premiums by subsidizing basically the cost of the high spend patients with low spend patients, yeah.
Some that have been gobbled up. The vast majority of success on the exchanges has been through traditional insurers who have the foundation of the systems to do so. And the innovation in that space has come from the Medicaid insurers who adapted their processes and systems to be able to come onto the exchanges at a lower cost point. So it would be very hard. It would be very hard to do that, right?
Okay. Quick break. For tech time.
Just a few days into my iOS challenge, I started to look a little differently at the Apple users in my life. They describe Apple products with marketing slogans like, "It just works," as though they actually believe them. And it made me wonder, does Apple have one version of their products for the true believers, and then a different one for the scrubs like me? Because my time with the iPhone 16 Plus has been absolutely riddled with unintuitive design choices, unnecessarily limited functionality, and some of the weirdest bugs that I've encountered on a supposedly finished product in years.
Uh-oh.
But Mama Sebastian didn't raise no quitters, so I've stuck it out for more than the month that I promised, and I've compiled a lot of thoughts, both from myself and from helpful members of our community who see the world through more pink lady lenses. And some of their points were extremely valid. Turns out, I really was just holding it wrong. And over time, there's a lot about iOS that I've learned to love even on my own. But there's also a lot that, well, to say how I really feel, I'd probably have to use language that might not sit well with my sponsor.
G-Skill, featuring a cast latency of 36 and 6,000 megatransfers of effective speed.
Cast latency of 36? What?
Their Trident Z5 Neo series of DDR5 memory is a great pairing for any black or white themed AMD build. Check it out using our link today.
Let's kick this off with some positive vibes. I am a big fan of the app library. I know it isn't new, but as someone who hasn't daily driven an iOS device in a while, it's new to me, and any effort to organize the pure chaos that most of us carry around in our pockets is much appreciated. Like finally, the ability to put your icons anywhere you want. I also appreciate the intuitive and slick way that iOS handles switching between picture-in-picture and background media playback. I mean, how cool is this? As for my other primary use of my phone, phone calls, that got a big improvement too. I get so many different kinds of calls these days. Phone, Teams, WhatsApp, whatever. And iOS streamlines this experience by unifying the interface between all these different apps, which is especially nice when I'm in the car. It even consolidates my call logs, so I don't have to remember who prefers what when I mash a contact to call them back. Multi-widget stacks are super.
My favorite thing about getting an iOS call when you're driving is when you push the answer phone button on the car, and then it doesn't actually answer the phone call on the phone, and then it like messes up, but then your car audio gets stuck on like phone quality, and then you can't find a way to make it stop playing your music on your phone, but it sounds like it's coming through a telephone, so now you're just stuck driving for the next 15 minutes listening to your Spotify on your phone, but it sounds like it's coming through like an actual handheld telephone. Fuck, I hate the iOS fucking bullshit.
Super cool. I don't actually know if they're new or not, but I don't really care. Quick access and high information density always get a thumbs up from me, and I use them all the time to quickly check the weather, quickly check my calendar. Now, I've heard that these are a thing on newer Samsung devices as well, but look, this video is not a comprehensive comparison matrix of every software feature that's ever existed. It's my thoughts on coming back to iOS after an extended absence. And some of those changes really are refreshing. Screenshot management has leveled up in a big way and is full of nice to haves. Like, I love the ability to quickly delete rather than archive my screenshot after I've shared it with someone, and I love the little pop-up in the dynamic island to help manage my AirPods. If they're paired to my laptop already and I'm sitting working, but an incoming phone call comes in, it'll be like, hey, want me to grab those? And I'm like, yeah, thanks. Actually, any sort of interaction between the iPhone and other Apple devices is pretty great, like my Apple Watch unlocking without needing to mash in the pin if I have my phone unlocked nearby. So efficient. Speaking of efficiency, I probably plugged this thing into my nightstand to charge maybe 4 or 5 times over the entire month plus that I was using it, which probably sounds bonkers. But what I found was that just plugging in during my daily commute, plus the occasional longer trip, was enough to keep me going for literally a week at a time, unless I was binging a show all day or something. iOS then noticed this and piped up with a suggestion that I switch to 80% maximum charging in order to prolong the life of my battery. That is the kind of proactive user handholding that I can really get behind. And the same goes for how aggressive iOS gets about prompting the user to mute or block app notifications and tracking. To be clear, Android's tools for managing these things are pretty good too, actually very granular. But what Android doesn't do is get all up in your grill about them like iOS does, which results in an experience where if you get a notification on your iPhone, you can be pretty darn sure that it's something you wanted to see.
Well, there are some things that Android gets in your face about that iPhone doesn't, that I appreciate and I miss. There are not many features I ask for my phone, but I appreciate this on Android. When you send an alarm on an Android phone, it tells you how long that alarm is for, so you don't accidentally mix up like AM or PM or whatever. It doesn't do that on your fucking iPhone. So if I set an alarm, but it's accidentally for like 11 PM instead of AM, I'll just set it, and like a retard, the phone is like laughing at me, being like, yeah, we got you, chief. We'll wake you up at 11 PM, wink, wink. And then you wake up at like noon, you're like, fuck, what the fuck, no.
Or you can easily get rid of it. Now, pretty much everything so far has been mostly to do with the software, but I've got to say, I kind of like the hardware too. The screen on the iPhone 16 family is incredible, with outstanding brightness for watching videos outside, not to mention their super dim mode that supposedly gets all the way down to 1 nit and makes nighttime reading way more comfortable for me. Oh, here's a fun one. You know how phones are supposed to be, phones? I'm getting way better call and data reception near my house, and not just against my ancient Note 9, but even against my wife's Galaxy S23 Ultra, so I can finally close my garage door from the driveway. All right, you guys think that's enough positivity to appease the Apple stands? If not, I could probably keep going for an entire video's worth. But, unfortunately, I could probably go multiple videos about the things that I didn't love so much, so we should probably address at least some of them. Let's start with how slow the device feels. Okay, no wait, hold on, step away from the comment section. I recognize this is absolutely not a slow device, but that makes it all the more frustrating when it feels like Apple's interface decisions are holding me back. Like the animations, they're beautiful. I love the way the home screen icons come flying in the first time that it loads after you set up a new iPhone. But I don't need to see it every time I unlock my phone. Guys, I've got urgent Facebook Marketplace doom scrolling to do.
Wait. Okay, I'm like a snappy interface guy. I get really triggered when there's like unnecessary animations and shit. I feel like I have never in my life, and I'm an iPhone hater, I don't think I've ever in my life thought that the iPhone animations were taking too much time. What a weird complaint. Okay, fuck. I want to shit on iPhone too. Don't worry. His next complaints will be better, I'm sure.
Do. And yes, before you ask, I did turn on reduce motion, and I even tried prefer crossfade, another
Oh, I haven't even fucked with these options.
gorgeous animation, by the way. But none of that had the desired effect of getting the fluff out of my way so I can just use my phone. I'm just picking what I get to look at while I wait for the UI to catch up with me. While we're at it, by the way, why is this setting and so many other useful ones hidden away in accessibility options?
This is true. The settings for the Apple menu, I feel like somebody designed a really good settings menu and they were like, okay. We want to launch this product by, third quarter 2024. Did we get the random clown show settings guys in yet to just fucking yeet like 6 options that you would expect to be in one menu into another menu yet? Has that happened yet? No, we'll bring those guys in ASAP.
I can't change that unnecessary slowdowns are going to bother me. Like this thing that Apple does, where it animates all the steps to get to a setting that I have searched for or clicked a shortcut to. The rationale that I've heard for this behavior is that it's trying to teach me where I should have gone. But I got there with a shortcut. Is that not an okay way to do it? Who cares if I know all the breadcrumbs? Adding insult to injury, depending on how I try to go back, I get to click through all of those screens that it zipped through on the way back to the thing I actually cared about. Which brings me to a pretty big subject. Going back on iOS is objectively bad. And, okay, all right, something can't be objectively bad, but what it can be is objectively inconsistent, which from a user interface and user experience standpoint is, well, objectively bad. I can't believe that Apple still hasn't mandated an official Apple way to go back. They seem to be big fans of the swipe in from the left, but they only use it just enough to trick you into thinking that it should work all the time, and then bam, an app hits you with clicking on the top left like my old iPhone 4, or canceling in the top.
Damn, I don't use that many apps, so maybe I just don't have the experience. The only thing that's annoying about this that I've ever used, I don't use it that much, is Snapchat. When for some reason Snapchat, you like swipe to the left and it brings up new stuff, and I'm like, what the fuck? Snapchat is the only app I have that genuinely like triggers the fuck out of me. Like I'm close to breaking my phone anytime I open up this piece of shit app, and the swiping is fucking weird as fuck.
Right, like this, and even the occasional swipe in another direction. Now, app makers absolutely share some of the blame for this, but guys, we are 17 years into this experiment, so I think it might be time for Apple to just take the darn reins, or maybe in other cases, loosen them. Overall, I found CarPlay to be pretty okay. My car doesn't have a physical button for previous track, so if I wanted to have media controls and...
What do you even use Snapchat for? Oh, well, I like it because it's impossible for anybody to ever share anything from there, right? I heard that it's literally impossible for anybody to look at stuff because it's deleted all the time, right?
my map on screen at the same time. I had to use split screen, which I don't prefer. I like a nice big map, but that's probably more of a me problem, and you can't blame the handset makers for all the dumb things that the car manufacturers are going to do, so let's not worry about that. Let's worry about the bugginess that I experienced. Every once in a while, the volume would crank itself, and I ran into this issue twice. It's probably worth noting I saw this with some random Bluetooth earbuds too, though, so maybe it's not CarPlay related. This issue about the bugginess that I experienced. Every once in a while, the volume would crank itself, and I ran into this issue twice.
There's some weird thing sometimes where iPhone wants to be able to control the volume of every Bluetooth thing you're connected to, but sometimes, like when it connects to a new Bluetooth thing, it will crank the Bluetooth volume up to what your phone volume was, and all of a sudden it's like, ah! And it's like, holy shit. Oh my god, it's fucking annoying.
It's probably worth noting I saw this with some random Bluetooth earbuds too, though, so maybe it's not CarPlay related. Actually, now that I think about it, there were more problems with audio. Notification volume would occasionally go super loud. There's all cabling, which is...
I still, Dan got mad at me because Dan was trying to like tell me that I fucked my notifications over something on my phone. And because I was telling Dan, I don't know how to, I've just given up on ever making notifications work on my iPhone. I don't know how to ever do it. And he's like, oh, you got to turn off the alarm bell and then the focus do not disturb thing. I was like, okay, I do that. But like if you send me a message on any app, it just doesn't show up. But if you wait like 5 or 6 minutes, sometimes like all 20 of them will come up at the same time and like make a bunch of noise. Like, and it's just like, I've given up ever even trying to understand how the fuck notifications work on this fucking dog shit, horrible fucking operating system.
Which is apparently an iOS 18 bug. And compared to Android, adjusting the volume level of anything you aren't actively using is super non-obvious. Like, Andy, how do I change the volume of my like system tap sounds when I'm listening to media, for example? You just mute it. No, but like, how do I change the volume of that? No. If you've never touched Android, this is gonna blow your freaking mind. No matter what I'm doing, if I touch the volume button, I can adjust my ringtone, my notifications, my media, and my system sounds. The fact that that doesn't exist, iOS users should be rioting in the streets. I know this next one is gonna get lost in translation as Android and iPhone users are coming from completely different experiences here, but oh my goodness. The iPhone keyboard is missing so many things that I completely take for granted as basic functions of an Android.
For the first time in my life, I felt so seen and so heard. I don't even know how my phone knew that. I guess because Google is listening to everything I do. An iOS thread on Reddit popped up, and it was like, how many people have this issue? And it's when you're typing something, and instead of putting a space between every word, you're putting a period between every word. And I'm like, how am I really, can I not type correctly on this phone? I've had it for a fucking year, and I just still can't use the keyboard correctly. Oh my God. There are so many stupid fucking things. I hate the iPhone keyboard. I hate it. I hate it. I hate it. The thing on my, the Google Pixel, that keyboard was 1,000,000,000 times better than this stupid fucking keyboard on the iPhone. Oh my God. Can you explain the reason you got an iPhone again? Because I got cucked by the iPad and I love it. I'm obsessed with it. So I figured, why not just get an iPhone and an iWatch or whatever the fuck. Fuck me.
Android keyboard. For example, while the iOS keyboard does let you hold down a key in order to modify your letters with whatever diacritical mark you need, or even sneak in the occasional thorn, yog, or esset, Android lets you use the same technique to access numbers and...
and the auto spell correct or whatever bullshit on iPhone sucks compared to Android. People will say just download the keyboard. I tried to put the keyboard on the phone and it's not as good. I don't know if there's a difference or what, but God, it's so shit.
And punctuation from the first layer of the keyboard. You can even dial in the delay so that you barely have to slow down to insert one of those secondary characters. And this is an absolute godsend for those of us who write our texts like our AP English 12 teacher might grade us on them. Now, I tried switching over to my usual Alt keyboard, Swift key on iOS, but somehow, all these years later, it is still trash on the iPhone.
Yep.
Core features are missing,
It's
like the
dog
aforementioned
shit.
long press tuning, and even the ability to resize the keyboard, and in general, it just feels off, with worse predictions and a more
Yep.
tedious process for going back and making corrections. Like maybe
I'll be typing like a thing. I'll type like the information, and the spell check will be like, I'll be like, seriously? What? You can't really? You've no idea? I don't know, man. The spell correction on the iPhone shit is just fucking a wacky, wild clown show sometimes. Oh, hold on one second.
maybe I want to type RHIS. It autocorrects to this. I go back one, no, I meant RHIS.
Oh,
and
he's doing
I should
it.
be able to fix the accidental autocorrect and my capitalization at the same time. On the iPhone, not so much. Now, if I had to guess, I'd say that this limitation probably comes down to Apple giving keyboard apps far less access to user inputs, which is probably a good thing, but it makes for an overall significantly worse typing experience on my keyboard of choice.
True.
Which also just would occasionally disappear, leaving me with the default. Weird. Now, one thing that's better about iOS is the super responsive long press keyboard shortcut to reposition the cursor. I like it, but I also don't struggle with fine motor control, and it's usually faster for me to just tap the point in the middle of a word anyway, so not being able to do that on the iPhone actually kind of drove me crazy. Now, I've got
Because it,
going back on iOS is a
oh fuck fire. Because it always like makes you bring up the menu. It goes to the front or like back of a fucking word, or the
Objectively.
start or end of a word. Fuck, where was I just at?
feels
Oh.
off with worse. Hey, the account setting was giving me all these extra pixels on the plus. I'd really like to just tap the point in the middle of a word anyway, so not being able to do that on the iPhone actually kind of drove me crazy. Now, I've got a lot more things to get through, so let's rapid fire a few. I can't get to the home screen without physically swiping the screen after authenticating, and then it's animation time again. Just get out of my way and let me use my phone. I can't change the size of the app grid. I'm stuck at 4 wide. On the normal iPhone 16, that would be fine, but if you're giving me all these extra pixels on the plus, I'd really like to use them. It's like
Yeah.
they intend for their larger devices to just be for the elderly or people who have trouble with the smaller screens.
I feel like I have a Navi. That's what they used to call the old like tablets for children. What the fuck?
And here's a weird one. I ran into this problem while rearranging apps. I think maybe the ones I place manually might behave differently than the ones that are automatically placed. Sometimes it just gets confused. I don't know. In fairness, Apple's new to this whole putting things where you want them thing. And here's a funny one. When I was migrating in the first place, Apple's Move to iOS app failed twice before actually working. And even then, it basically just copied SMS, photos, and WhatsApp. I had to manually sign into everything, including my Google account, which left me wondering, what exactly was the point of this? I'm not sure, but I'd like to talk about that Google account for a minute.
Uh-oh.
In the past, iOS had an account section in the settings app where you could centrally manage and sync your different accounts for email, calendar, contacts, all that kind of stuff. That seems to be gone now, but I work for a G Suite organization, so I'm gonna need my Google Calendar to tell me what it is that I'm doing today. This is where past experience with iOS got in my way. The account setting was gone, and I couldn't find an obvious way to add an account in the calendar app. So I started looking for workarounds and ultimately discovered that if you open the iOS Mail app, it immediately prompts you to add a Google Mail account, which will also sync my Google Calendar in the native calendar app. Now, I ended up getting attacked pretty hard for calling this out on the WAN show, but I'm holding firm that this is a prime example of spectacularly unintuitive design. The justification I was given for this is that app settings, including accounts, should be managed from within the Settings app and the Apps menu and then the individual app. And that is Apple's aspiration. But as we've seen with back functionality, Apple's aspirations don't always match reality. So let's play a quick game called Find the Account Management menu.
Uh-oh.
In the app. Yeah, this one's in the app. Another one that's in the app. They're pretty much all within the apps themselves. And while the first-party Mail app does have account management buried 4 layers deep within the menu, the Apple preferred way for some reason, it still prompts you to sign in that first time you open it, meaning that if you're trying to sign into an account from within an app, that is a perfectly reasonable expectation, even if you had no prior experience with other platforms. The good news for Apple, though, is that the solution to this is simple. When I click Calendars, Add Calendar, and then I have this account thing here, that should just be a drop-down that should prompt me to add another account instead of it just doing nothing. You're welcome. Now, to be clear, this isn't a deal breaker by any means. It just means the next time that an Apple fan tells me, it's just so gosh darn intuitive, I don't know if I'm going to be able to help it. I might actually laugh in their face. Maybe a little doom scrolling will calm me down, and oh boy. If you want the long version of this rant, you can check out the WAN show from a couple of weeks ago. But the TLDR is, when I flick my finger in my newsfeed or on Reddit, I expect the screen to move at the same speed that my finger moved and then decelerate from there. I do not expect it to move at whatever relaxed, chill pace that some Apple focus group has determined is the most
Okay, I don't know about this. I feel like I've never had this problem before. Wait. What? I don't know what is going on here.
aesthetically pleasing in order to hide their 60 hertz refresh rate. Another thing I touched on during that WAN show segment is buttons, particularly this new camera button here. Out of the box, I kept accidentally hitting it, only to have a user point out to me that I could configure it to require a double click. Huh, well that's super cool, I thought. I wonder what other apps I could make it No, camera and camera adjacent only. Speaking of the camera, boy was that ever an upgrade. Though, as someone coming from a 6-year-old device, I don't know what to say other than, I should hope so. And besides, my main focus isn't on the particular iPhone, but rather my overall experience with iOS 18. An experience I could probably go on for hours about, but Tim Apple, a more relevant meme than ever these days, doesn't have hours to watch this video, so how about I boil it down to just one thing that I need fixed? Let's talk about rotation locks. Most iPhone users I run into don't even realize this, but for a good 10 years now, you've been able to lock an iPad in landscape orientation, but not an iPhone. Now, we use iPhones as our teleprompters here at Linus Media Group, and because we can't lock them in landscape mode, we have to train all of our camera operators in a maneuver that we call the dip to reorient the screen. It's something we do so often that we don't even really think about it anymore. So, why bring it up? Because when I was going through the list of apps in my account, since the migration wizard didn't actually copy my...
Why not? That is such an expensive teleprompter. Why not just buy dedicated screens? Or just get tablets.
The maneuver that we call the dip to reorient the screen.
Okay.
It's something we do so often that we don't even really think about it anymore. So, why bring it up? Because when I was going through the list of apps in my account, since the migration wizard didn't actually copy my apps over like it said it would and I had to do so manually, I came across Jetpack Joyride and I was like, oh my goodness, I haven't played that since the last time I dailied iOS. It's been years. And I immediately fired it up. I played it for a second, then I put my phone down to make a note about something, and when I picked it back up, the game was upside down. I showed this on the WAN show as well.
Uh-oh.
I gave it the old wiggle, I tried to reorient it, but no. It would only work in one of the two possible landscape orientations. What the heck, Apple? These kinds of arbitrary distinctions, like which way is the approved landscape orientation, assuming I'm allowed to be in landscape at all, do nothing for your user, they do nothing for your profits. So why? To be clear, iOS has come a long way over the last few years, and it can do so much more than it used to do. Find My is a godsend, Spotlight still rules, AirDrop is legitimately super cool, as long as everyone around me has an iPhone. But Apple still has some work to do to be willing to accept that after the iPhone leaves the factory, it's my iPhone. And if I want to hold it like this, instead of like this, or I want to use it as a teleprompter, that's my business. If I want to move the dynamic island to the other side, that should be my decision too. And until Apple's willing to truly embrace that, rather than begrudgingly give us little breadcrumbs, I just don't think this is for me. Which doesn't mean that it's bad. If you love your iPhone and it works for you, you are not wrong. Just don't get upset.
Okay, one more.
So let's get right into it. Cenk, are you now a Republican?
Okay, so a lot of people on the left have that theory. The definitive answer is no. So look, I've been a populist all along, and what's fascinating to me is how much politics in America has changed. Because the left-wing populists, like the Bernie Sanders type of guys, have been standing a post waiting for our right flank to appear at some point. Because giant things like getting money out of politics, you cannot do alone. The left wing can't do it alone. The right wing can't do it alone. The only way to fix it is an amendment, because you got to go above the Supreme Court. You need 3/4 of the states. So for me, I've always thought, if we don't get united, we're never going to beat the establishment. And
Okay, so the people against the money in politics are the two billionaire guys? Is that?
The establishment has been my enemy forever and ever and ever. And I wish we had beaten them, through Bernie in 2016 or 2020. And I'm not saying that they're knocked out. I mean, the establishment is gigantic. They've got billions and trillions of dollars, and they're going to make a huge comeback in the 2028 primaries. But on the Republican side, they've largely been defeated. And so here's what my left-wing friends don't understand. They think you guys are all MAGA, and MAGA means it's a cult, and you're never going to disagree with Trump. You're never going to disagree with each other. And that
I hope he's going to say, oh, we disagree with Trump all the time, like when he did this random irrelevant thing that's not even an important part of his platform. I wonder if Cenk will ask, give me like one or two significant policy disagreements you have with Donald Trump.
You are like their father's Republicans, but you're not their father's Republicans. And so our side, I've been trying to get them to realize that Joe Biden, Nancy Pelosi, all these folks that take the money, they're not on your side. They're on the establishment side, right? And for you guys on the right, when I used to debate you, and I don't mean you guys in specific, I mean in general, all I would get is wall-to-wall talking points. Oh, Mitch McConnell knows what he's doing. Oh, John Cornyn is the best. Oh, George Bush, Dick Cheney, et cetera. And we've been around forever. We're the longest-running show in internet history, right? We're the first YouTube partner channel ever. That makes me like the original YouTuber, right? Wow. And so I battled the Cheneys. I battled all those guys in the Bush years, right? And then I hit Obama from the left, and people got super mad. I mean, that's part of the reason why I had a huge blowout with MSNBC, and I left MSNBC because they didn't want me to hit Obama, and they didn't want me to hit the Democrats. So I've been doing that from day one. And guys, today, I think that, we could do something historic. I think that we could actually unite the left flank and the right flank. And I've got a model for how to do that, and I want to run it by you guys. I've got a couple of rules for the internet that I want to run by you guys. Rules sound bad, right? But hold on, I think you're going to like these rules. And then I want to see, hey, is there a couple of things that we can unite on right now on this show, make the show a little bit historic, and say, hey, this is what the internet thinks. This is what the populace of the right and the left think. Let's go tackle the establishment and make it happen.
Okay, so before we do that, can I ask you a couple questions?
Of course.
So for you, election night, we had you on. You came, you spoke. You're a fiery guy. You're a true believer. You're a guy that we've all seen you. You're not a guy that you actually are not acting. Like you actually believe what you believe in, and you actually get upset. You really are upset, right? So I know it's going to sound weird. I think there is an element of Alex in you. There's an element of you in Alex. I know you don't want to hear that part. I'm telling you as a person that's a viewer, you guys have been on both for a long time, and you guys have both been hated by opposing sides, and I think you guys have a lot of similarities from the messaging that you believe in. Now, you may not agree with each other, but that's the messaging. What do you think with all these ideas? Like, sometimes for me, I'm running a business, and I have some ideas. I create a comp, and the comp is not growing the company. But I say it's the right comp. A year later, nothing's happening. But it's the right comp. 2 years later, 3 years later, 5 years later, nothing's happening. Then you have to sit there and say, by yourself, and this is not easy to do. I've shut down my channel twice for 3 months because I sat down with Mario and I said, look, the last 100 videos, we haven't had any views that get 100,000 views. Why is that? We only had 2 of them. And we had 40 videos over 1 million views. Why have our last 100 not performed? We kind of talked about that a little bit when I was on your show as well. And then we shut down. We're like, okay, let's regroup. Watch those videos they used to do. Watch this year. What's happened with the climate? What's changed? Is the market pivoting? You're not. Are you, with your values and principles that you had, the results? For you, what did you notice where you said, maybe I was wrong with these principles that I thought were the right way to think about?
Did he just openly admit to grifting? That we were putting out views, or we were putting out videos, but we weren't getting enough views. So we had to shut our channel down and then reevaluate to see what would make our channel get more views again? Is that what?
I know I was right about this. This is the one thing that whether I'm right or wrong, I'm not compromising. It's my conviction. But I know I was wrong about these 2 things. Is there anything that you personally went through?
Yeah, there's a tiny on policy, but more on how to react to the right wing, which is a really, I think, interesting conversation. So look, I get why the left is skeptical, because what happens is usually there's a pattern, and unfortunately some former TYT hosts have done this, where they beseech the right wing, they start agreeing a little bit and then a lot, and then next thing you know, they're pulling a Reuben or eating a Reuben sandwich, and I don't eat that, right? And I don't do that. But what has happened to the core of your question? So there's tiny things around policy, like I believe in no cash bail, right? So if 2 guys commit a sexual assault, one is poor and one is rich, the rich guy pays bail, gets out, the poor guy can't, and by the way, they're accused, it's alleged, right? You don't know, but the poor guy stays in jail for mainly being poor. So it makes sense to be for no cash bail. But what wound up happening is California, for example, reduced some felonies to misdemeanors, which they didn't really tell us. It was in a prop measure. I voted for the prop measure, but they never actually said in the ballot measure, we're going to reduce penalties for these crimes, which are some significant crimes. And when you combine the 2 things, repeat offenders kept getting out of jail and doing another crime and another crime and another crime. And I realized, okay, wait a minute, we got an issue here. So on no cash, first of all, on the issue of taking the felonies to misdemeanors, once we found out what was going on, I'm like, look, I've been to every progressive convention there's been and every progressive conference, talked to every leader, et cetera. I never heard anyone say, let's take felonies and turn them into misdemeanors. I don't know where the hell that came from, right? So I said, okay, now that I see that, okay, if you commit 3 offenses, then you're a repeat offender and you have to put up a cash bail. Okay, so if you're a guy, oh my God, G-Son, you got accused and you didn't do it, okay, no cash bail, right? But if you do it 3 times, you got to put up bail, no question. And now we voted in California for Prop 36, and I made the position against what you guys would call extreme left or radical left. I'm trying to call them max left now to be respectful, right? But those guys said crime is imaginary, and I said no, crime is not imaginary. Crime is definitely real, and crime is going up. And guys, if we don't do something about putting these folks in jail if they're repeat offenders, we're going to lose everybody. And they said you're nuts. That's not going to happen. Then Prop 36 in California was saying put them back to felonies, right? It won with 70% of the vote. 70% of the vote, right? In California. And that's my point to my friends on the max left. Like, you guys want to be maximalists, but that's not where Democratic voters are, let alone Republican voters. So I was never in favor of making them misdemeanors, but I was in favor of unlimited cash bail. Now that I've changed that, but you see, it's tiny. It's a tiny change based on what I saw, based on experience, based on these guys getting out and doing it again. But the main thing, Patrick, is before, when I battled the right wing, it was a wall, right? I'm just like, nobody's listening to one another. They're just doing talking points. I hated it. And then MAGA looked like they were 100%. I'll be honest. I mean, in 2020, I was super pissed. And I said, look, I don't want to talk to Trump supporters. All I hear is the same thing. Trump, and they never waver. So what I'm saying to the left now is, no, I'm seeing something new and different here. The MAGA base has changed. Okay, that doesn't mean they don't like Trump. It doesn't mean that they're not right wing. But there is a significant portion of the MAGA base now that is, in my opinion, right wing populists who are actually anti-establishment, actually anti-corruption, actually anti-war. And what I'm trying to tell the left is, take the win. We've been standing opposed here for 20 years, trying to cut the Pentagon, trying to be anti-war, getting money out of politics. If people say yes, for God's sake, that's our lost tribe. Those are our right-wing brothers and sisters who are Americans, who are populists, who agree with us. Let's go fight the establishment together, because if we're united, they cannot stop us.
Are you at all in a place right now? You're registered what, Democrat?
Yeah.
Okay. Are you at all at a place where you've thought about being a registered independent or libertarian?
So look, the reason I became a Democrat is because in California, if you're an independent, you can't vote in Democratic primaries. And so I wanted to vote for Bernie Sanders, et cetera. So I became a Democrat, and I don't have any problem staying in the Democratic Party. I ran for president in the Democratic Party as a protest candidate against Biden, as you remember, right? Mm-hmm. But now we're in a situation where we've got realignment, where there's a left-right spectrum, then there's a populist establishment spectrum, right? So I am center-left, but I'm way populist. I'm 100% populist, right? So things are moving. If it turns out, and the parties have switched before, if the parties completely switch, then I don't have any allegiance to a party label or name, right? But right now, the Republicans are still right-wing, Democrats are still left-wing, so I'm going to stay there.
So why do you think the Democratic Party lost a Rogan, lost a Tulsi, lost a Bobby, lost a Musk, lost a Trump, all these guys were former Democrats. Why do you think, and let's set Trump aside, because maybe Trump's Democrat in the 80s and 90s. Let's kind of come to the names recently, like Musk, like Rogan, like Tulsi, like Bobby, these guys. Why do you think they're losing these names?
Yeah, so everything's a little bit different, and every person's different. So Tulsi, I think, was
none of those people were even like actual strong Democrats, right? Like
always secretly a right winger. But Bobby Kennedy Jr. was not. He was definitely a Democrat, right? And so he's a decent example. So Bobby has opinions that a lot of people on the left don't agree with, right? To which I say something revolutionary to the left. So what? Okay, he agrees with us on the environment. He agrees with us on housing, on anti-corruption. He doesn't agree with us on vaccines, fluoride, et cetera, right? Why don't we have a conversation with the brother? Why don't we include him? Why don't we do a real primary? And if he wins, he wins. If he loses, he loses. Do you believe in democracy or don't you believe in democracy? And look, he would have easily lost a primary, in my opinion, in the Democratic side. But what the Democrats, and this is a culture problem, right? So on policy, I'm totally left-wing. But when you talk about culturally, there's a couple of issues that are going on. Number one, I've always been when I was a kid, I was a Hulkamaniac, right? Yes. And I love all you folks who love the art and the opera and the ballet and stuff, and there's nothing wrong with that. My sister does, and my friends, etc. But I'm not that guy. Like when I listen to NPR, I'd always be like, why are they whispering? Why don't they speak the fuck up? Right?
Very soothing.
Yeah. So culturally, I've always been a populist too. But the real problem with the left and the Democratic Party these days culturally is, we don't want you, we don't want you, we don't want you. If there's a 2% disagreement, we want to cancel you and get you the hell out of here. Right wing, in my opinion, has their own version of cancel culture. We can get into that. But with the right wing, you agree with them 2%, they're like, oh, welcome in, come to the party. Oh, yeah, come on in. And if one party's constantly pushing people out and the other party's constantly inviting them in, well, at some point, the party inviting them in has a bigger tent. And you not only win the election, you win the popular vote. So Democrats have to get out of this mindset of, you must agree with Democratic leadership. And if you don't, you're ruining unity. Shut up and get back in line. No, hell no. Young Turks have never been in line. We're never going to get in line. We're not going to get in line for MAGA. We're not going to get in line for the Democratic Party. And these idiots said, bow your head to Joe Biden. And Pat, I was on the show. I was on every show. And I said, what are you guys, nuts? His brain is falling out of his ear. He's shaking hands with invisible people. He thinks his uncle was eaten by cannibals. You guys are lunatics. And I will not agree to being a lunatic for your agenda. So look, to me, look, I want to propose this as rules for the internet.
I want to hear it. Go for it.
But it's so important that both the right wing and left wing agree with this, right? So let me bounce it off. Number one rule.
Here we go.
When we disagree, we fight. And there's nothing wrong with that. Nothing wrong. It's America. Okay, we disagree. We got freedom of speech. Let's rumble. Let's brawl. There's nothing wrong with that.
What do you mean rumble and brawl?
I mean, of course, rhetorically, politically,
Debating.
not violent.
I'll throw down right now, Joe.
Because as simple as that sounds, that was not popular with the left the last 8 years. We've invited so many people from the left, and we will always invite them, but unfortunately, they don't like to fight as much as the other side likes to fight. Okay,
yeah,
so
rule number two of the internet.
Just to be clear, that's absolutely fucking not true. The right will never invite actual hardcore disagreeers onto their platform. It will only be softball people that will agree to play softball politics. That's the only way that happens. Or people that can make them more popular.
Afterwards, you must have a beer together. Okay?
Tip O'Neill and Reagan.
Yeah. And so what I mean by that is you don't have to love the other guy. You don't have to agree with him. But we got to go back to being Americans, right? So, okay, we have a fight. Then let's go get a beer. So what? Okay, I don't agree with you on healthcare. I don't agree with you on trans issues. And I know some people say, hey, look, is there a line that goes too far? Yeah, for some people, there's a line that goes too far. But in general, Let's go back to listening to one another. We've been yelling at each other. And by the way, I mean, I'm guilty of it too. I mean, I think as far as yelling on the internet goes, to your point, yeah, I've done that many, many times. But I try to have a beer afterwards so that we can still be a country together, okay? And last one is number 3 is, when we agree, let's do something really bold and unite, okay? And if we unite, we will be invincible. Because look, as I said in that tweet, my mortal enemy is the establishment. The one that says, no, the politicians are honest. No, the donor money doesn't affect anyone. You know, this absurdity of CNN and New York Times pretending that the donor money doesn't affect the candidates and it doesn't affect the bills. When they start talking about legislation and we're talking about, hey, can we negotiate drug prices? And you're not talking about big pharma spending billions, if not trillions of dollars in lobbying and donating to the politicians, et cetera. No, it's utter corruption. And we cannot beat that corruption unless we unite. So if the right wing, if I'm right about the right wing populists, and I made a bet with one of my co-hosts last night, okay, well, I can tell you about that too. But if I'm right about the right wing populists and we unite on some things that we agree on, I think we're going to be invincible and finally beat the establishment.
So I like that. Number 1, if we disagree, let's fight, let's debate. 2, afterwards, let's have a glass of, let's have beer together. 3, if we do agree, let's unite and let's celebrate it and let's come across as a united crowd, united group. I like that. Going back to the conversation with Trump. So Trump won, and he got how many votes? I'm looking at it right now, 77 million votes. Okay, and the only person that ever beat him is the GOAT, Joe Biden. But he got Jordan. Yeah, he got 77 million votes himself. And by the way, just so you know, even the great Obama in 2008 got 69 million votes. In 2012, he got 65 million votes. Hillary Clinton got 65 million votes in 2016. And in 2020, Trump got 74, and now he got 77 million votes, 7 battleground states, all that stuff. Why do you think he won so single-handedly, like it's not even close?
Yeah. Well, look, the popular vote was close, but so now...
I like how he just blows over, like, all the fucking rules. Like, okay, I don't care. Now, tell me why you like Trump. Tell me why did Trump win the election again? Like, oh my God, it's so fucking masturbatory. Holy shit.
Why do you think he won so single-handedly, like it's not even close?
Yeah. Well, look...
Have we basically counted everything up? 75 million to 77.2 million. Not even close. Not even close. 48.4% to 49.9%. Not even close. It was a fucking blowout.
The popular vote was close, but so now when the Republicans win the popular vote, it feels like a mandate because they usually lose. But he did. He won fair and square, right? And he won with a big vote, and he won all the swing states. So as you guys know, I was warning that he could easily do that, and my Democratic friends were like, "Oh, you're crazy. Trump's not going to win." No one I know likes Trump. No, you're in a bubble. Everyone's in their own bubble, right? And probably if you'd asked some MAGA guys, they probably thought he's going to get 80% or something, right? No, we're in different bubbles. And what's interesting, Pat, is that I speak both languages. I speak populist and establishment. I speak right wing and left wing. I can understand and I can translate for folks, right? So why did Trump win? Why was he popular? Because he's at least trying to appear to be a populist. Whether he actually is a good question and is going to be settled by the next 4 years, right? But look, I'll give you the example I always give. This random guy, Nick Smith, doing a strike at a Waffle House in Western Virginia, and we go interview him in the 2016 election. And he says, look, all my family's coal miners, right? And our reporter asked, why do you guys think of voting for Trump, right? And he says, look, Hillary Clinton comes here and tells us we're going to lose our jobs and there's no hope. Trump at least has the decency to lie to us. Okay. And he says we got hope, the future is bright, et cetera, right? And that makes a huge difference. Yeah. And so, and then our candidates are so terrible. And, you know, after an election loses, you see cable news, CNN, MSNBC, what do? They blame the voters, they blame Russia, they blame Bernie, they blame me, they blame everyone except the candidates. So Kamala Harris, it was a terrible candidate. When you go out there and you're like, I will only do talking points, I will not have any real conversations, then you're not authentic. Trump appears to be authentic, even though in my opinion he lies a lot, but he appears to be authentic, whereas our guys look like corporate robots. And what's the lesson they learned? I guarantee you in the next primary, the Democratic establishment will run Gavin Newsom, Pete Buttigieg.
Can you explain how people can unironically call themselves populist? Like the tragedy of the commons seems so obvious. I don't know, people like it. It sounds cool. It's good. I don't know.
They're like, no, these are the new improved corporate talking robots, right? And that's not the point. Authentic and populist. And by the way, Pat, all across the world, look at what just happened in France. The left and the right got together, both populists, and said no to the establishment. Enough with, taking it to the average man.
Listen, I'm with you on the establishment side. Because you saw the other day Bernie Sanders agreeing with Musk. What? Yeah. What is that all about? I mean, that's both of them are anti-establishment. So that is the area of agreement. So I agree with you there. I love the fact that everybody is now using the phrase future looks bright. I love it. I love Elon the other day tweets out.
Okay.
Remember, the other thing you'd have to have if you had an insurance pool, given that you have to make payments timely, is you've got to have enough capital backing the insurance risk. And so where do you raise all that capital? That's another thing.
So I think there's so many more questions I have on that I'll punt for when we get to the ACA.
Yeah. So look, the two things, we got a $4 trillion system. It's almost 20% of our GDP. It was not anything like that in the 1950s. There are a number of coverage welfare programs, if you will, that have been put into place, many of them done in that context in that time, not only with good intention, but reasonable projections that things would not have grown like this. Medical innovation, I mean, just look at the number of patents in the industry and how they've grown. the combination of medical innovation, drugs, devices, service innovation, procedures, along with coverage, created a virtuous cycle, coverage that was disconnected from individual accountability, created a virtuous cycle of spend increase that has gotten us to this place. And it has been faster than GDP. And at the same time, it hasn't broken the system because the US economy has been thriving, right? I mean, the arguments about affordability that we may get into would be, well, at this level of expenditure, the US economy, it's draining the US economy from being competitive. Well, I'm not sure that that's actually true yet, okay? And we can get into forecasting where it's gonna go. I'm not sure that's true yet, okay? All of the dollars and benefits that have gone into creating a healthcare system have created millions and millions of jobs. If you look back over the last 20 years, healthcare has probably created more jobs as a sector than in any other sector in the United States.
Yeah, I was trying to think of that some. The only two things that I could even put alongside it as huge sectors probably still don't create as many jobs would be energy and agriculture, right? Those would be the only two industries that could even come close to being in the same zip code as healthcare.
And what's unique about those three? Energy, putting aside the defense industry, energy, agriculture, and healthcare are the three most subsidized industries by the government.
Fuck, that too.
The three most subsidized industries by the government because they have obviously by far, right? I mean, agriculture has been for a long time. Energy is very much so today, not just from a national security perspective, but in terms of the innovation needed there. And healthcare has been so, again, as we said, in the US, probably since the early 1950s, certainly since 1965 when you had Medicare and Medicaid come about. And so the expenditures have just grown. Obviously, aging contributes a bit to that, and there's some differences we can outline with other countries if we have an interest in it. But aging contributes a little bit to that. And then obviously, as business has grown, the value of this pre-tax benefit, as more and more people are employed, has grown to continue employer-sponsored insurance as a vehicle of private insurance to match the public programs, Medicare, Medicaid, and otherwise. And so the expenditures have grown significantly. One of the things that comes up is, well, what have the industry participants done to actually help with this problem? And the argument will always get made, well, it's grown so quickly they've done nothing. And I don't think that's even remotely true. Sadly, I think you could be in a situation where expenditures would have grown even faster. So think about this. From a hospitalization perspective, the number of bed days per thousand, so how many hospital days per thousand population, have fallen by a half since 1980, okay? The number of physicians per thousand people has more than doubled. The industry has added significant physician capacity in order to help with access. Do we have shortages still in certain areas? Of course we do. But the number of physicians has doubled from about 1.5 per thousand to 2.8 per thousand. So the industry has expanded its capacity. The insurance companies, through their managed care programs, have demonstrated the ability to manage cost. If the consumer were accepting of some of that management, that's a different issue to get into, which is how to do managed care in a way where it doesn't reduce and frustrate consumers or physicians with respect to choice and professional freedom. But make no mistake about it, tight managed care has controlled costs for a short period of time until there's been a bit of a revolt in terms of that. And product choice within insurance companies has created choice. So if you go back, you had Medicare for a very long time. Sometime around the late 90s, 2000, Medicare Advantage really took off. Why did Medicare Advantage get created? Medicare Advantage was a way to create product and benefit choice for seniors that wasn't just traditional Medicare, right? They'd have a choice.
It's sort of the equivalent of the private insurance in the NHS system where you get the state-sponsored thing, but you want more choice.
Right, and the government gave an incentive. I mean, I think that payments to private insurers as an incentive to get into the Medicare space were almost 115% of regular Medicare expenditures because they were trying to incentivize bringing people into the system, privatizing part of the system, providing better benefits, giving them choice, and ultimately have that managed care hopefully reduce cost. And the jury's out on that, right, in terms of whether it's really reduced cost or shifted cost or whatever. But it is a highly functional private system built on government dollars called Medicare Advantage, and increasingly managed Medicaid is doing the same thing. So the industry participants have done a lot in many ways over the last, in particular, 30 years in this space to try to curb costs without necessarily reducing this fundamental driver that defines our healthcare system, which is the desire for immediate access and choice. And that defines our system, is that desire for immediate access and choice.
I would even add another point to that because we're going to go deeper on those too. But you even mentioned that the number of physicians has doubled basically over the last 40 years, while the number of hospital bed days has fallen in half.
Yeah, and the number of hospitals has declined.
The other thing to keep in mind is weak physicians in this country spend infinitely more than in any other country to become educated, and therefore the debt that they assume upon completion is also a big part of what drives. Presumably, we must have the highest physician salaries in this country.
Yeah, the U.S. has the highest physician salaries relative to other countries, but I would tell you that physician compensation on a real basis since the 1990s has been flat or declining. I mean, that is a stunning fact. It grew rapidly from the 1950s, roughly until the early 90s. But since then, physician compensation has been flat or in many cases declining. And that has a lot of implications given the medical training debt that you're describing about our ability to continue to grow the pool of physicians to meet the growing demand of healthcare services as the population is still aging, but also aging with chronic illness so that their needs are more intensive rather than not. And I'm not even yet getting into mental health, which has been an area that's been underinvested in for the better part of 3 or 4 generations, which, as we now realize, actually costs a lot not just for mental health, but the impact on physical health, which drives our healthcare costs, especially in the context of chronic illness.
We've been talking a lot about choice, but is it worth maybe spending a minute to explain to people some of the terms that I'm sure they've heard, but might not fully understand? Like, what's a PPO? What's an HMO? What's value-based care? How does Kaiser work? Like, can you explain what those things are so that people understand when they're making their selection at open enrollment, they get a sense of what those things mean?
The way I would think about a PPO plan is it's one in which you're procuring insurance where you have relatively open network choice. Okay, so there may be a preferred network where you get somewhat of a discount, but you have the choice to go wherever you want, however you want, etc. HMO, a health management organization, is one in which that choice is narrowed. You're making a choice upfront to come into a program with less options, such that the penalty for going out of that set of options is high and theoretically comes at a lower cost. Okay, and then you have systems within those that kind of operate in the frame of one of those two models, if you will. In the US, the PPO business has been growing significantly faster than the HMO business, back to the point around choice, right? It's let's use the right word. It's more important than cost right now, and has been more important than cost to consumers. That's not to say that people aren't feeling the costs of healthcare increasing and the burden of healthcare costs increasing in the way that they're getting their healthcare, but they're choosing PPO more than not. The marketplace is speaking. The simple answer on an example like Kaiser is largely a closed network health management organization where what you're doing is you're buying an insurance product through Kaiser. It's a not-for-profit that you're buying an insurance product through Kaiser, and you're agreeing to stay within their network of hospitals, doctors, etc. They have a physician group that is largely bilaterally aligned to them on an exclusive basis. That's a for-profit entity, the physician group. And the two of them together produce a product that ought to cover the vast majority of your healthcare needs. And in theory, based upon that integration of care, you either get lower cost or better outcomes or both. And again, I think the jury, from a long-term perspective, relative to other models, is out, but it's innovative. And it's worked in some places really, really well.
And they don't try to cover everything, right? So if you have a child that's born with the most obscure congenital cardiovascular malformation, they might just say, you know what, that's something we will just send up to UCSF because they've got the right person there.
I mean, my personal example, my mother had a rare form of brain cancer. We had terrific oncologists at Kaiser who were incredibly dedicated and knowledgeable about oncologic care, who, without hesitation, sought expertise from UCSF when they needed it for the more sophisticated parts of her care, including letting her go there. So my personal belief from personal experience is that clinicians do make a lot of the choices at Kaiser. They get knocked sometimes that somehow there's a corporation sitting there telling them what to do. And yes, it is managed care. And yes, there are restrictions on, in some ways, how they construct their system. But when you have an esoteric problem, no one stops a physician from sending you to the right place there, in my experience. So, and all systems that are in managed care have out-of-network expenditure for rare things. But I think that's a really important point and worth bringing up from that perspective. But you have these systems then that work in certain places and don't work in other places that effectively. Look, the vast majority of the country today, from an employer-sponsored standpoint, is working in some form or another of a PPO system where people have choice because that's what they want. And again, that choice comes with a cost, as we've talked about, right? And that maybe explains some of the differences between us and other countries.
I was just going to sort of say, I grew up in Canada and I still have experience with the Canadian healthcare system because my entire family is there. And I don't know if you have experience there, previously, because I know at McKinsey you did a lot of work for different provinces and stuff like that, and obviously through the NHS. And here's my take, and again, it's so anecdotal that I'm curious if it's reflective. My take is that if you needed heart surgery, if you need a aortic valve replacement and a root repair and a cabbage, there's a surgeon in Canada that's just as good as the surgeon in the US. Meaning the top 10% of the surgeons in Canada and the top 10% of the surgeons in the US are going to be indistinguishable in that regard. You're really going to get great care in that regard. The difference is you're going to wait a heck of a lot longer. The hospital experience could be entirely different. Obviously, you're not paying for it.
Well, I think you have to be careful about that. You're paying for it,
of course, through your taxes. Yes, yeah. You're not paying through it. It's not coming out of your wages directly. You're not paying out of pocket. To your point, again, you're shielded. You're more shielded from the cost. But boy, if you're dealing with something like you've injured your knee and you need an MRI, like the difference in how long you will wait to get that is it's immense, right?
Yeah.
The access, the speed, the choice, the access is really what goes down. The quality is not really the thing that has, at least in my experience, been degraded in a system like Canada.
I think there are excellent physicians around the world in developed countries all over the place. There's no question about that. And I would tend to agree with your description of the top physicians in both places. I would draw one distinction, which is I think emergency care is accessible on an emergent, immediate basis in most developed countries.
Destiny, that's a fucking lie. People don't want a choice. We want not to have to deal with private insurance at all. It's an entire industry created to facilitate suffering. That's great, but the majority of the American consumers apparently disagree with you, so kick rocks. Sorry.
Now, the interventions that they may take, how interventional it may be, how aggressive they may be, using the most modern technologies or modern devices or whatever, may be different. But emergency care is available, right? If you had a heart attack, immediately in Canada, went to the emergency room,
Yep.
you're going to get treated very well. I think where things change is the elective care,
Yep.
right? And by the way, heart surgery can be an elective, because you might think of elective as, cosmetic surgery. No, I mean, a hip replacement, a knee replacement when you can't walk, a cataract replacement when you're half blind, or heart surgery can be elective. You're just scheduling it in advance. And you're absolutely right. In many parts of the world, the wait times for those things are much longer, right? The cynical view of that is, of course, that it's a cost management system. But what I would say is they've made a choice.
Yeah, it's an infrastructure.
It's an infrastructure choice, but it's so the way you would describe this in economic terms is that you have universal coverage, which creates the same moral hazard problem that we described here. People would consume infinitely, but they choose to cap it with supply side interventions, constricting the supply or available supply of services in order to manage the demand. And what does that do? It creates wait times, right? Or accessibility problems. And you have a lot of Canadians who come into the US for healthcare on a more immediate basis, or they buy private insurance, which can reduce the wait times from that perspective if they can afford it. I mean, for better or for worse, right or wrong, nowhere in the world, no matter what healthcare system you're in a developed country, do you have fully equitable access. Okay? Those with means, there's always a system to procure better access from that perspective. The thing that's different in the United States at scale that I think is interesting is not just the focus on consumer choice, but the United States has become comfortable in healthcare being the driver and leader of innovation. So in healthcare services, that is the proliferation of academic health science centers that conduct research, much of which used to be supported exclusively by the NIH, which is a brilliant construct over the history of the United States, to really fund basic research and innovation, now clinical research and innovation, and increasingly funded through private industry. And that has driven a large proportion of the innovation in the world. Like the science that supports pharmaceutical development, for example, comes out of US academic health science centers, right? Largely speaking. And then you have US-based pharmaceutical companies that develop 75, 80% of the world's pharmaceuticals. And you can keep going and we can get into drug costs, but it is a unique feature of this country that we have chosen to make that investment for the rest of the world. As I said the other day, it's no differently than we seems to have made that choice in defense, right? And there are differences between the two.
This is what I want to come back to, right? So we're going to go into PBMs because I'm amazed we are as far into this podcast as we are, and we haven't discussed PBMs. So we're going to get right to it for the people who are listening to us going, how have you not talked about drugs yet?
Yeah.
But here's the fundamental difference. You made a great point, right? So post-World War II, Bretton Woods Accord, the U.S. makes a deal with the rest of the world effectively, which says there's a Cold War coming, and if you choose to be our ally, we will provide you security. Specifically through our Navy, we will ensure that your ships can pass freely throughout this entire world. We will not plant a flag on your soil. We might use military bases, right? We're not here to be conquerors. We're not here to be emperors. But if you pick our side, we will assure your security. And so that's an example of how we greatly subsidized defense for the world. But we got something out of it. Now, when we are subsidizing drug costs for the rest of the world, because, as you point out, we develop all the drugs, it's not like we get different drugs than everybody else. Everybody else in the world gets the same drugs we developed. Everywhere else in the world has price controls that lower the cost of that. And in true economic fashion, it's sort of like somebody is squeezing down on the tube of toothpaste. All that toothpaste is exploding in the United States with drug costs.
Right.
So the question becomes, what are we getting for subsidizing the rest of the world's drug price?
Yeah. Well, first, I think you got to look at this in the context of when it developed, right? You're back to the question of, could anybody have predicted that we were going to go from 4%, 5% of GDP to 17%? Could anybody have predicted that the drugs that were going to be developed and the advances in science would result in multiple therapies for common diseases and orphan diseases, which are rare diseases, that might cost over $1 million a year, right? Could anybody have predicted that?
The vaccine was German? Which vaccine are you talking about? Not the mRNA ones.
I think the system as it was set up, especially because drug development at that time was new, in particular small molecule development, and then somewhere in the late 70s, early 80s, you had the advent of biologics. Which
BioNTech, the only reason that company was still in existence was because it was invested in, because it was saved from bankruptcy like 20 years ago by an American pharmaceutical company. There's a reason why it's called the Pfizer vaccine and not the BioNTech vaccine, my friend. I'm sorry.
Then grew into commercial products, especially in the mid 90s, raised the bar on innovation pretty significantly. And also everything that happened with respect to genetics opened up a whole broad range of therapeutics that didn't really exist before when you were just taking small molecules and at scale testing them against targets.
Right.
Now, the cost of drug development went way up. Therefore, the price of drugs went way up, at least in the United States where you have a market. Now you end up in a situation, if you just fast forward to what people are thinking about today, especially because it's all over the news, you got GLP drugs that may have broad benefit, okay, for the population in one form or another. Why? Fundamentally, the drugs may be effective, but it's because our health status is poor. In a country where the health status wasn't so poor as it is in the United States with chronic illness, the cost of those GLP drugs might not be projected to be so high because less people would need them, right? And we can get into that a little bit around healthcare policy and what the national objectives for health would be. But you have common drugs now for common conditions that are extraordinarily expensive, right? I mean, there are alternatives that are much cheaper that might do a significant fraction, if not for many people, all of the job. Metformin would be a simple, generic example that might take care of many of those things for people at a price point that's a thousandth of what. But nevertheless, you have this innovation, and you have also a culture that's obsessed with things like medical approaches to weight loss that has proven to be difficult to achieve through other means.
Was there ever a place when the U.S. What's the closest the U.S. has come?
Where you're getting that story, it's not true. BioNTech was a startup created by German billionaires. My understanding is that BioNTech was facing either bankruptcy or closure in 2000 and before 2010, and I think it got a huge influx or infusion of cash investment from I don't remember if it was Pfizer or a group managing Pfizer or something. Maybe it was around this 2009 acquisition.
Come to trying to enforce some measure of price control in pharma in the U.S.?
Well, remember, there's one thing that's important to understand is that the Medicare Modernization Act that was passed in circa 2000, okay, which we've talked about some of the other aspects of it, forbade HHS from negotiating for drugs as an entity as CMS. I mean, we legislated that.
Right. We gave away negotiating
yes.
power.
The Inflation Reduction Act, which was passed in the Biden
I'll look it up. I'll put it on my list of things to look at.
aspects of it, forbade HHS from negotiating for drugs as an entity as CMS. I mean, we legislated that.
Right. We gave away negotiating
yes.
power.
The Inflation Reduction Act, which was passed in the Biden administration, has cracked that door open a bit for negotiation because the dynamics of drug pricing, the nature of the drugs, the widespread applicability
Sorry, just go
of
back to 2000.
Yeah.
Did the U.S. government, at least for Medicare, say we will resign the right to ever negotiate? Was that a concession
Explicitly.
to pharma? Was that a concession to pharma to get something else?
Well, how it came about in the lobby, I don't know the details, right? I mean, I'm sure there was, but it was an absolute direct concession that forbade HHS from
Yes, but what did they
negotiating.
get in return for that concession?
Well, there were a whole set of other things that were part of the Medicare Modernization Act that we talked about, like Medicare Advantage was created and scaled up, which created a way to potentially have managed care, maybe manage the utilization of drugs, and therefore maybe curb the expenditures, create formularies that might encourage people to use generics rather than branded drugs if they were equivalent. There were other mechanisms put in place to try to control what people did understand as rising drug costs. They've just risen more substantially in the future. Again, I go back to context at the time, what should have been well intended, and what were the unpredictable
Because the
consequences.
cynic is going to say, Sam, that sounds to me like pharma had better lobbyists than anybody else.
I mean, we live in a political system in which our representatives that we elect vote for us, and they are subject to lobbying.
Yeah.
Right. So that's the nature you would hope that would be superseded by good policy decisions at some point in time. And I'm not saying Medicare Modernization Act wasn't a good policy decision, but I don't think it was a predicted effect what would happen. And so I think cracking that door open is good. Look, we get into these philosophical debates about we're a free economy, a free market economy. The government should not be engaged in price controls. But think about this. Doctors are price takers from Medicare. Medicare sets their reimbursement. It's price controlled.
They're price takers from private insurance for the most part.
Hospitals take Medicare prices as they're given. So Medicare is a monopsonist, right? They're a monopsonist. At the end of the day, they've applied it to doctors and to hospitals and other infrastructure-based care where they set the prices based upon their purchasing power. It just hasn't happened yet on the drug side. And you have to think, obviously the debate is, how do you do that in a way that doesn't deter innovation? Is there a sharing with the rest of the world that needs to happen? Or how do you do it in a way where if it's just the US, it doesn't deter innovation? Because that innovation has been incredibly beneficial to us in a number of different ways. And again, we're going to get into health status and outcomes and why they aren't so good. But it has been helpful. And at the same time, leave enough of a return that actually the innovation won't stop, right? And start to take advantage of some of that purchasing power. And I think that's going to be an ongoing policy debate, now that door has been cracked open. And I think what's new is that both the more, and I really don't want to get into politics, but both the more populist brand of Republicans and Democrats seem to have understanding that drug prices are on their radar screen on both sides, maybe in different ways, right? So the industry will evolve, and we'll see how that goes.
Well, let's talk about this drug thing, because going back to the very beginning of the discussion, a third of the 85%. So again, I'd like to anchor people to it. We're spending $4 trillion a year on healthcare.
Can't innovation just be done at universities? Universities don't create drugs. They just engage in general research, basically, but not bringing a drug to market.
15% of that is administration. That's something that exists virtually nowhere else. Of the 85% of that $4 trillion that's not administration, roughly a third of that is drugs and devices, and more of that is drugs than devices. So drugs are a really, really, really expensive part of the U.S. healthcare system. It also should be patently clear to anybody listening to us right now that we in this country are singularly paying infinitely more for every given drug than our peers are elsewhere for the exact same drug. Let us now talk about the elephant in the room, the blessed PBM.
PBMs. Okay. So let's talk about what a PBM is.
I literally make drugs out of uni, Limeo. Yeah, you make drugs that have been like off patent now that were manufactured by other companies. Your university has never created or brought a drug all the way through phase 3 trials ever in the history of its existence because your university is not capable of doing it. It can't bear the cost, it can't bear the risk, and it just doesn't specialize in doing that.
Because there's two issues with the PBMs that we should talk about. One is what do they do?
Yeah, what are they? Let's just explain what they are.
Start there.
Yeah.
Then there's the question of who owns them and how do they work and is that vertical integration helpful or not helpful to the system, which we can get into. But the PBMs, in essence, are organizations that formed as intermediaries between pharma companies, insurers, and pharmacies, where you get much of your medication, in order to help manage an increasingly large complexity of drugs.
Why aren't generic drugs the default when prescribing drugs? Aren't they generally? Won't a doctor usually prescribe a generic? Is that...
drugs. I mean, today there are probably 15,000 pharmaceuticals available. The PBMs were designed to do a few things. Understand the market.
Shouldn't public entities be able to take on risk better than private R&D? The nice thing about capitalism and risk is that it allows the market to do a fuck ton of research before people decide where their money or investment should go in. Doing that on a government level could theoretically lead to way, way, way more waste.
Market for those drugs. Make formularies that were either broad or restrictive. Manage benefit plans for employers who were looking to have preferred pricing on certain drugs versus other drugs, right? So they were created to try to say, okay, we've got a lot of expenditure here in the drug arena. The choices are complex. The number of drugs has gone up, 15 or 16,000, whatever that number may be. And we need entities that help people make more informed decisions, in some ways at scale through employers or insurers, and in some ways at the retail pharmacy level when individuals are going to fill prescriptions, by the way, which includes things like generic substitution and things of that nature when that's appropriate and is allowed. That's what they were created to do, okay? What did that create? It created a complex payment system because it used to be you buy a drug, the money goes to the pharma company from the pharmacy buys a drug, they pay the pharma company, you have a direct interaction. Or you're in a hospital, you get a payment, the hospital buys the drug from the pharma company, you pay them something for that drug, you administer the drug and you get paid as part of your global fee for taking care of that patient, whatever the case may be. The PBMs came in the middle.
When did they show up?
Well, I think the growth of PBMs showed up, forms of them showed up in the 80s, but the growth of PBMs has been in the last 20, 25 years and really has taken off recently for reasons that we'll get into about their ownership structure, if you think about it that way, which has brought more scrutiny to them than used to be there. You've created a system in which now money is flowing less directly in many cases through the PBM. So the pharma companies may sell product, but depending on what the PBM is doing in terms of committing market share to the pharma company, the PBM may earn a rebate. Okay, so you have a rebate that the PBM can earn. Now that rebate, the PBM may share with the insurance company or the employer who's signing up for that PBM service because they're saving them money through that rebate. So you have this new flow of dollars. Again, the idea behind this was to have better formularies, better understanding, allow people to have choice. Do you want a broad formulary? Do you want a narrow formulary? Of course, incentives are incentives, and part of what's happened is that with a rebate structure, you can imagine incentives can exist for higher price product to move through a PBM and pass through, and some of that being offset.
So the U.S. healthcare system, a lot of middlemen, it's a clusterfuck of complicated payment schemes and everything. It's fucking annoying.
With rebates on both ends.
Yeah, so this is the classic example of, and I'm sure, I don't know who said it first, but it's been said a million times. Show me how a man gets paid, and I'll tell you exactly how he's going to act. And this is straight from the horse's mouth. I will not identify this individual other than to say it is the CEO of a major pharma company who shared with me that he wanted to price one of his drugs at a low level, right? He wanted to undercut similar products on the market and come in at a lower price. The PBMs flatly told him, we will not put your drug on the formulary until you triple the price. Don't worry, we will make it up to you with a rebate. I mean, this is, I don't even know how this is legal, right?
Wow.
I mean, it just doesn't, you understand why that is happening from the incentive system. How is this legal?
Yeah.
How do these things exist?
Yeah, well, I mean, I think in some ways, it's what we've said about most of the U.S. healthcare system, right? Which is well-intended, reasonably constructed structures that might have been effective in one setting, as things have changed, become less successful in this setting, and economic incentives can sometimes change to drive behaviors like you're describing, which I hope is not the norm, right?
Is that not cartel behavior? I would have to know the specific example of what's being talked about and what, if I don't, because what he's saying sounds blatantly illegal to what it sounds like, but I mean, I don't know.
I hope is not the norm.
But even if it's not as overt as a situation like that, subconsciously, what we've done is removed any incentive for a drug company to be concerned with the sticker value of the price of their drug, right? It's a meaningless entity because of these machinations and payments that you've outlined, where rebates and kickbacks completely change the economics. Again, the system was so opaque to begin with. Yeah. You know, you've already outlined this idea where we're so uncoupled from our decisions. I don't just mean as patients, I mean as doctors. We have no earthly clue what a drug costs when we prescribe it. If I'm trying to decide to write somebody for rosuvastatin versus atorvastatin, it couldn't possibly enter my stream of consciousness why one of those might be 10 times more than the other.
Yeah.
And yet we continue to just add unnecessary cost to a system.
Well, I think you're getting at some of the more fundamental questions around what is innovation, right? So do we reward the innovation of a statin itself as the innovation, or do we reward the Me Too's that come after it, which sometimes grow to be larger than the original statin?
Yeah, and sometimes
itself.
they're better, right?
And it could be a different
Tirzepatide
manufacturer.
is better than semaglutide.
Absolutely. They could be better.
Yep.
But how do we reward that innovation, right? What happens oftentimes is a floor is set in terms of the reward for the initial innovation. As things get better, rather than competition with more molecules driving price down, it often drives price up because the market moves to the better and better product. I mean, this gets back to supply side intervention in other countries, right?
Yeah, which is a very interesting point. I never thought of it that way, which is how much they throttle supply in a system where demand could be unlimited and they have no control over
and
demand.
In some of those countries, they will just say, look, 90% of the benefit is accrued with simvastatin, which was one of the original drugs. You're not going to prescribe atorvastatin or rosuvastatin, right? That's just not going to happen. And so there's a limit. And you have to qualify with certain criteria that are stringent to get to that more expensive for the incremental 10% benefit. We don't work that way in this country, right? Physician choice around physician decision-making, around those choices. And we've made the decision that we want to be able to afford that type of choice for the incrementally better drugs, sometimes better from a side effect profile standpoint, right?
Yeah, for sure.
Can drive some of these decisions. We've made that decision on an individual basis rather than a population basis. And I think the point that we're talking about today is it's getting expensive, right? And it's getting expensive to the point where 17, 18, approaching 20% of the GDP may be okay. But the next 50 to 75 years, if that grows to 35% of the US economy, I think then you have some very, very serious arguments about how sustainable is that if the US economy doesn't grow as rapidly as it has been growing.
Well, now I'll bring up my favorite thing I've heard recently when Paul Tudor Jones was speaking with Andrew Ross Sorkin, and he wanted to put it into just the simplest terms for why there was no rational argument why anybody should buy a US Treasury, right? Which was, imagine I have $700,000 of debt. You've lent me $700,000. My income is $100,000 a year. So what does that mean? That means he's taking that from $35 trillion of debt currently and $5 trillion of tax revenue. So my income is 1/7 my debt. And as you pointed out, I'm going to continue to assume $2 trillion of debt a year in perpetuity. And I'm saying to you, the US bondholder, the person who's going to buy a 30-year treasury, I have $700,000 of debt. I make $100,000 a year. I want you to lend me $40,000 a year for the next 30 years. And I promise you at the end of 30 years, I'm going to pay it all back. I mean, what do you have to believe for that to be true? You really have to believe I'm going to have a remarkable growth of income or a remarkable reduction of cost somewhere along the line.
Or a devaluation of the currency.
Yeah, I'm going to have to inflate my way out of this thing. And again, none of these things are desirable. But when you say healthcare costs over the next 2 decades could potentially go from 20% to 1/3, how in the world could we imagine that the other costs contract to accommodate that?
That's right. And that's the issue, right? Which is that ultimately that's a very difficult proposition to actually get your head around and believe. And in particular, I think we should get into the outcomes in the US to explain what we're getting for all those dollars.
Yeah.
But you're right. It's very difficult to fathom expenditures getting to that level. Now, one optimistic point of view on healthcare expenditure growth out there is that if you just look at the aging curve of the population, in particular the boomers and how they're growing, and even with increasing lifespan, the aging of the population in the US peaks at about 2032-ish timeframe. You can look at different projections.
2032.
So in the next 8
all
years,
these old
we're going to kind of reach
fuckers.
the peak
What
of
the
aging.
fuck?
In other words, when I say aging, the number of people will grow every year that enter the above 65 Medicare world. And that number will peak, and then will start to come down.
So you and I will be right there.
We will be right there.
Yep.
That's right. And then that number will start to come down. It's not just the boomers, obviously, but I'm just giving you the demographic. And the question is, when that comes down, will that mitigate this long-term trend of healthcare expenditure growth? Okay, so that's the optimistic view, that there is a mitigant built into the system just with the aging of the population. Now, think about all of what you do. If at the same time, the consciousness and awareness of just basic interventions in health status can improve health status even a little bit from a chronic condition standpoint, those two, because that's not going to be a 1 year or 2 year phenomenon, it takes a decade. Those two could together make a big difference in US healthcare cost expenditures. The challenge in terms of what's happening on the other side, especially in this context of debate around immigration, is we're not growing the population of people under 65 who generate the economic productivity to fund the system to get to 2032, right? If you go back a number of years, like the 80s, and you look at the number of people pre-Medicare, so call it 40 to 65 years old to Medicare, it was 2 times the population. 2 to 1.
2 times we're paying into...
Well, I'm roughly saying highest economic productivity is 40 to 65. 2 times the number of people as you had Medicare. That number is trending towards 1.0. by the time we hit 2032. So the generators of economic activity, and economists will get into this discussion of, well, one of the reasons the U.S. can afford to spend more on healthcare is we tend to work longer than much of the rest of the developed world, right? 65, people talk about working into their low 70s and others. So we generate more economic wealth to subsidize this healthcare system and other things that we may want to subsidize in the country. But that drop from 2 to 1 is significant, and that's happening at the same time that we continue to have this aging. So while it's interesting to think 20 years out, I actually do think for the next 10 years we got a problem, right? We've got expenditures that we know will grow because of the continued aging. The demographics are clear, and we have a reduction in the work. The only way to fill that is, of course, to have the U.S. economy still be an attractive place for immigrants to come and work of all types at all levels of work in order to fill that demographic hole. And we've got to get our head around that problem. I mean, who would have thought immigration is related to healthcare? We talked about this election. People are talking more about immigration than healthcare. Well, actually, it's relevant to healthcare because healthcare is such a large part of the economy. Everything comes back to it in the end when you think about it at a macroeconomic level.
One of the things you pointed out that I was unaware of, although it totally makes sense, and
Is the idea that the U.S. finances other countries' low prices just unfalsifiable? Could it not be that we could also have low drug prices too? I mean, well, the question would be, would there be the money in the system to do the research to create those drugs if it wasn't also for collecting all the payments from other countries as well, right?
we could argue it's another sort of potentially shining spot is most people are very familiar with the fact that relative to our peers as developed nations, the U.S. has a pretty paltry life expectancy in aggregate. Most people can point to two things that tend to be the biggest drag on this.
Uh-oh. How edgy are we going to be with this? It's going to be black people and infant mortality. Let's see.
So the first has to do with fetal maternal health. The second has to do with overdoses in sort of middle-aged men.
Oh, okay.
And, we spent time on both of these. These are, related to both access to health and deaths of despair, respectively. But the point you made...
Oh, actually, I think it was the big increase in... Are overdoses here including suicides? Deaths of despair, I think so. I think it was suicides that actually drove our life expectancy down.
Was, once you reach about the age of 70, your life expectancy in the U.S.
Wouldn't the counter to that point just be to point to the profits of the pharmaceutical industry? I don't think that the risk-adjusted profits of pharmaceutical industry are that big. It's just really not true. It's just a lie. It's just a lie everybody says. But I mean, if you believe it, then yeah, that is true. But the reality is, I don't think risk-adjusted. I don't think pharmaceutical industry is any more profitable than any other industry in the United States. But there's no point in saying that because nothing will ever convince you of that. So
succeeds that of any other nation.
Yeah, right.
Like this is, to your point, that's when the system actually kicks in terms of dragging out life pretty well.
So let's talk about life expectancy. And I think the most important context to consider here is that whether you look over the last 50 to 75 years, we've used 1950 as a marker, or 100 years, life expectancy has improved remarkably. A lot of that has to do with infectious disease and other things, and that's fine. So when we say our life expectancies in the U.S. are I think what we're really asking is why are we 3 years
behind everybody else? Especially when we're spending
the most, we're not getting the best
100%
outcomes,
more.
right? And I think you make a really good point, which we've talked about before, which is somewhere between 60 and 75, the equation slip. We go from dead last to first. Because the medical system we've created that optimizes 75
100%
outcomes,
more,
right? And I think you make a really good point, which we've talked about before, which is somewhere between 60 and 75, the equation slip. We go from dead last to first. Because the medical system we've created that optimizes for access, quality, sophistication, technology, the best drugs, flips.
Yeah.
And it's actually quite effective at creating longevity from that standpoint. We can all discuss whether or not, to use your language, the lifespan is improving with or without the health span.
I'm curious what the actual risk is, honestly. How often are pharmaceutical companies actually spending billions on a bunk drug? Pretty often. I'm pretty sure the average cost to bring a drug to market is around $1 billion when you factor in all the failures.
But nevertheless, the lifespan, is the best in the developed world. So what's going on, in the younger population? I think you hit on some of it. Look, infant mortality is 2 to 3 times the rate that we see in the rest of the world. Why? We have a higher rate of teen pregnancies. There's a higher rate of sexually transmitted diseases. You've got drug and substance abuse issues that play into that. And some of it is just, again, going back to this notion of access for care in the prenatal window. And that's really important. 2, which you didn't really touch on, I would describe as, broadly speaking, injuries and homicides.
Yep.
I mean, the rate of those in the U.S. is significantly higher. I mean, homicides 7 times the rest of the developed world. I mean, some of that goes back to gun violence, of course, that's unique in the United States versus others. If you look at this over a long period of time, by the way, some of the mortality in the younger generations had to do with wars. But put that aside, is not something as relevant today. Drug and substance abuse issues and just the flow of things like fentanyl and others that are creating a different generational impact of mortality is quite significant. Obviously, the penetration of things like HIV and AIDS, and even though that's become a chronic disease.
Isn't the federal government the perfect entity to handle that risk rather than corporations? I feel like I'm about to do like the most fucking Econ 000 fucking Milton Friedman, Chicago school, suck off of capitalism ever. The reason why money is a good driver or incentive when it comes to analyzing risk is because everybody can get in on it and everybody else is competing for your dollar, right? So if I have $10 that I want to invest in a given thing, I'm going to go to where the money is. Okay, so I see that like a treasury bond or treasury bonds will get me so much. Okay, I want to be that at least. I'll look at companies that have long track records. I see they deliver, decent profits. I see that whatever other companies, that are in industries that are really profitable, or I'll look at like broad funds that I'll track market, right? Basically, whenever there's places for me to invest my dollar and earn money, I will invest money. If a company pops up and like, oh, we can get you 20% profits. Well, everybody in the whole market is going to be looking at that company. There's going to be a lot of analysis. And companies that are starting are going to do a lot of analysis to try to return money to people that invest in them. So if drug research for revolutionary new drugs is done by a profit motive, then there is a lot of analysis that goes into figuring out what's the best drug to research. If it's simply or purely government directed, then there's a lot of questions about, well, how do we allocate funding for drug research? Because if that's just held subject to voter desires or politician desires, then there could be way more waste or inefficiency in terms of allocating money towards drug research because people just want to see a certain thing cured, even though it's not very likely that you'll ever find a cure for it, or people just want to, or just for whatever reason, people are just, voting to, or the politicians want to invest in a certain thing. It's just probably not the best way to allocate funding for it. The best arguments that I've seen in favor of stuff like that would be things like lottery systems where the federal government might, or not a lottery system, the federal government might make like a reward for researching and developing a new, which I think we already do. They're called, what are they called? There's prizes given for like drugs that treat rare diseases, so that it's not just the most common diseases, yeah.
Over the last 25 years, it's been a significant driver of mortality. So you have these features that create excess mortality in the US, especially under the age of 65. Now, when you combine that with the fact that our rates of obesity leading to things like
Fine, that's a great argument for pharmaceuticals and therapeutics. What innovations come from the administrative bloat of the private insurance industry? People conflate insurance and pharmaceuticals. Americans seem like they really want to be able to choose which hospitals they go to, which drugs they can get, which things they, or whatever. And the choice to Americans is important enough that we want to pay a premium for it. It seems to be the case. That's the argument that some other paper that somebody linked earlier made, or a Substack or something. And then that's apparently the argument that this guy's making, which I guess could be, yeah.
That with the fact that our rates of obesity leading to things like diabetes and heart disease when you're older are higher than the rest of the developed world. You have these unique issues, plus you have a fundamental health status issue that we're now recognizing costs the healthcare system money. Obesity and its consequences don't just emerge when you have out-of-control diabetes 15, 20 years later. The expenditures...
The motive for corporations isn't the best drugs, it's the most profitable. If that was the case, then nobody would ever invent a vaccine. So you're just wrong. When you say best drugs, like profitable drugs, like you might look for the most profitable, but there might be like 100 other people that are investigating how to create that most profitable drug. So chances are it's going to be way more cost to actually do the research. There's way more competition for it. So it might be better to investigate how to do a different drug that might not make you as much profit, but there's not as much competition. It's a risk adjustment. So, and also there are federal rewards for finding cures or drugs that cure like rare diseases.
The lost productivity in the workplace, all of those things happen earlier. So when you put those two together, you have a health status problem. And by the way, they overcome and overwhelm the things we're better at. I mean, oddly enough, we're better at getting our vaccinations. We're better at cancer screening. We're better at treating blood pressure and cholesterol.
Do you think we can only go to certain hospitals in the UK? No, you probably have broader, you can probably go to multiple hospitals, but your wait times and shit can be like pretty cringe sometimes. And the staff get paid not that much as well. And a lot of the drugs you get come from American pharmaceuticals.
In this country, back to the pharmaceutical, culture, we smoke less significantly than other parts of the developed world. But guess what? That's being overwhelmed.
Why can't the government just negotiate and fund drugs rather than in-housing all of it? I mean, when you say negotiate drugs, you're effectively talking about price controls. The government can do that for some things, but I mean, like a price control means that you are setting a ceiling that's lower than what the company would set it to anyway, which means that there are some drugs that just won't be created because it's not going to be profitable to do it. Now, whether that's good or bad, I mean, it's a choice, I guess, as an American society we have to make, but our military is single payer and still highly innovative. This is a kind of boy's point. Does our military innovate drugs? I don't know as much about like TRICARE investment into pharmaceutical research. I just don't know the answer to that.
By these other factors, in particular under the age of 65 or 70, whatever that range may be. And if you look at those conditions, unlike how effective the public health model was in infectious disease in reducing mortality over the last 100 years, it's kind of been ineffective, right? I mean, the combination of public health and nutritional science together in the way...
Because wait times in the US don't exist, omega lol. you don't even know what a wait time means for healthcare if you live in the United States of America. You have no concept of what it means to schedule an MRI for 8 months out or for 2 years out to see a certain type of specialist. You have no idea what the fuck you're talking about.
Way that they've evolved in the last 25, 30 years have been ineffective in managing or dealing with these issues. Now, you can get into debates about were they adequately funded or not funded and the quality of the science and all that. But the fact is they haven't been that effective relative to other interventions. And we've got to deal with that, right? This isn't an insurance coverage problem. I mean, we pretty much cover everybody other than undocumented today in the US, or people that choose not to get covered, because there are options now for everybody, right? And in some states, we're even covering undocumented. It's not a coverage problem, okay? This isn't a system problem in many ways. The healthcare system can accommodate the illness. Right? It's a question of what led up to the illness that we haven't really fully dealt with in the country. And there's two forms. Again, societal issues, whether that be gun violence or poverty leading to bad access to prenatal care, injuries, et cetera, or the chronic diseases that seem to be more prevalent here. And how you fix that, you and I have talked about this for years. I mean, it's hard to change behavior. If you really want to change trajectory, you really want to improve health span, it's hard to change behavior. And the more of that can get built into the background that just changes the way people eat or changes the way people engage in physical activity, which could mean, designing cities where you have to walk to work the vast majority of time rather than drive, like many European nations have done. Those interventions themselves must have some benefit, right? Because you're seeing different outcomes between the countries. And
we need that sugar tax so bad.
Overwhelms all these other factors. I don't know that the healthcare system as it stands today is going to solve our cost problem that's driven by the factors I just described. It's certainly not going to just...
Can you make an argument for why you prefer the U.S. system over the Canadian system? I don't know if I prefer the U.S. system over the Canadian system. I mean, the argument in favor of it would probably be majority has to do with like drug R&D and maybe that's probably your biggest argument in favor of it. And I guess if you're wealthier or if you can afford it or if you work a good job that has like good healthcare options, then your average care is probably going to be better than it would be if you were in Canada, maybe. But
it's certainly not going to change materially our outcome problem. Tinkering with the different parts of the system, we might be able to affect cost. The outcome problem is a more fundamental problem.
Yeah, there's so much you've said there, Sam, which is pretty typical of your brilliance, which is you'll say something for 10 straight minutes, and at the end I'll be like, that's like a thesis that might have taken me a year to come up with. But what I took away from that, that's just again very insightful, is prior to the age of 65, the reason that we're in last place is a few of these things that are unfortunately more American than they should be, right? So we talked about access to guns, a culture of violence, things you haven't even alluded to, but greater mental health crises that just go hand in hand with all these things. Poor access to prenatal care relative to other developed nations, that's leading to a far higher degree of infant mortality. And these things just add up. We talked about the drugs. I mean, for heaven's sakes, right? Like we have a fentanyl pipeline coming into this country that's an embarrassment. And as a result, 100,000 people a year, more than that now, are overdosing.
By the way, it gets back to this issue. The border is a healthcare issue. Right? It just is. You can't escape it. Everything ties back in one form or another to healthcare.
What I really thought was interesting is, I talk about it in terms of medicine 2.0 and medicine 3.0, and I've talked about how our system is really good medicine 2.0, right? It's really good at treating chronic problems and grinding out incremental years of life when you're chronically ill. And that shines so much when you become a senior citizen. And that's how...
When I was talking about the military was innovative, I was talking about weapons. Oh, I guess. But even for that, you have private companies that create weapons as well, right? You don't have, and then the government is just the customer, no?
We leapfrog every other country between, ages 60 to 75. We go from last place in life expectancy to first because our machine shines. It really kicks in. And of course, it begs the question, why can't we have the best of both worlds? Like, these don't have to be mutually exclusive. You can preserve the latter, which is, we have all of these remarkable pieces of technology and innovation and access and infrastructure and quality that give us that boost of life expectancy at the end. Why don't we increase the number of people that enter that seventh decade of life? Let's increase that by 10% by applying better medicine 3.0 and access early in life. And by the way, I think you would increase it by more than 10%. The other thing that I think I keep playing back.
Right. So he's saying the government is taking on the risk rather than the companies. I don't know if the government is taking on the risk. I'm pretty sure the companies take on the risk, right? They bid for government contracts, no? Like the risky developments, I think, are still by the companies in that case, no?
Back in my head is I've always talked about these as three variables. So when I've talked about this, I've always talked about three variables. I've always talked about quality, cost, and access. But you've made me realize that choice is a part of that as well. And that's the part that I think is also very American. And I don't think we should be apologetic for it. It is just our culture. It is who we are. We want the best, and we want to be able to pick what we want, right? And that fourth variable puts even more pressure on the one that is unconstrained. So
which is cost.
That's right. So cost is unconstrained. We have said we want maximum quality. We want access, and meaning when I want it now, and I want to choose where I go. If I control those and I leave one to balloon, and that one is cost, away it goes. The other systems, as we've discussed, have said, no, cost is constrained.
Absolutely.
Cost is a capped resource. Now you see what's going to happen to the others, and that's where we get into the supply side throttle to lower access. Let's eliminate choice, and you'll still get decent quality. And that seems to be the choice that the rest of the world has made.
That is right. And I think,
Did the company say we are going to make the F-35, or did the government fund it? I legit don't know, but what company can just fund that kind of project? I think the way that it works, don't quote me, it's probably different on everything. I think it'll be like the government will say some shit. It's like, we want a plane that can fucking, we want a plane that can suck your dick while blowing up children at the same time or some shit, okay? We want a plane that can fly to fucking Mars, okay? But still be able to charge its batteries enough to watch 1080p YouTube videos on the way there and back. And so the government will put like some list of restrictions basically, or requirements, and then basically the different private military contractors will they'll bid for, okay, well, I think we can make this plane for 100 million, we can make this for 500 million, we can make this for whatever, and then people will.
You can't underestimate the power of, and I think, by the way, choice sort of fits in a broad framework of access, right? If you have enough access points and they're differentiated, that allows choice. If you look at many of these other systems,
I actually like to keep them separate. And even though in my former model they were the same, I think the way you've described it is better, because choice also means you have more drugs than you know what to do with. You have a formulary with how many thousands of drugs?
I mean, there are probably 15,000 pharmaceuticals available today. In one form or another. Some of them are repeats, but my point is, there's a lot of choice.
Right. And we'll do meniscectomies, we'll do meniscus repair surgeries, we'll do hip resurfacing, we'll do hip replacements. I mean, we'll do PRP. We'll do anything and everything. You have more choice here. This is the biggest buffet on the planet when it comes to healthcare.
So why is that? Is one of the questions that I think comes up. So I think, first of all, I agree with you. We cannot underestimate the power of choice. I mean, we learned that in the 90s with managed care, right? When it was quite constraining. And by the way, as I said before, that system lowered healthcare inflation. It only proved it for a short time because the backlash was so vicious against it. And I don't think we can go back there, like politically.
But how much financial risk does the company face before winning or losing the bid in relation to the size of the funding up for the bid? I mean, I imagine probably quite a bit of risk. I mean, these companies also sell other products and services as well, so they can kind of like, I think pharmaceutical companies, at least startups, are more likely to be one-hit wonders, whereas your private military contractors like sell things to different companies. Like Boeing, I think makes like civilian airliners as well. I don't know what else Lockheed manufactures, if it's exclusively defense, or if they also do like commercial satellite stuff or whatever. I'm not sure. But they've got like multiple products or services they sell. But I imagine if they fuck up something really big, I think they would probably like get fucked, right? Like if Lockheed would have fucked up the F-35 and they wouldn't have been able to bring that program home, maybe Lockheed Martin goes bankrupt, maybe. Like, I don't know how many other products or services they sell to the government, but
even from the standpoint of not politically, but just the way the system has evolved to create more options and more choice, it will be difficult to go back there. Limited supply side constraints, I think, at this stage, have and are becoming a part of the dialogue. As I said, Medicare sets prices for doctors and hospitals. They probably will start doing so for certain drugs. Okay, it's purchasing power. And one could argue that in some ways that's a form of supply side constraint.
Well, let's even start with the choice before that, because I always think we should start with the null choice, which is we can do absolutely nothing. We can sit here and say, Peter, Sam, thank you for explaining this system. I actually have a better understanding of it now. I want maximum choice, maximum access, maximum quality, let cost be damned. Let's just leave it alone. Let's revisit it in 5 years. How about that? Let's just come back in 5 years and tell me if it's 22%, tell me if it's 23% of GDP. Once it hits 25, we want to do something about it. Like we could literally just be ostriches and put our head in the sand and ignore this. Okay, let's put that aside and say, no, most people at this point probably think we should at least have some ideas for how we can manage this. So now that's your first point, which is Medicare has made the hospital and the physician a price taker. Shouldn't it be able to do that to pharma? Now, let's talk about what's going to happen. Because now you just added one more squeeze on the toothpaste tube while you're taking the cap off. Because if Europe and Canada and CMS force pharma to be price takers, what's going to happen to drug prices that are outside of CMS in the US?
Yeah, I mean, I think we have to avoid looking at extremes, okay? I mean,
but is that an extreme?
Well, I would say this. The ability, I don't think the people who are talking about this in a rational way in terms of actual pricing, which is not you or me really in terms of the policy, I don't think anybody's saying let's bring it down to the average of the OECD, et cetera, from where drugs are priced, right? The question is, are there ways to start to curb the inflation rate of price and actually rationalize some group purchasing capability? I think that the challenge with accepting the extremes is it will only fuel the discussion of innovation will stop, nothing will happen any further, and that's not going to happen.
No, I agree, but someone will have to make a concession, and I think that somebody is actually the shareholder, because I agree with you. I do not think innovation stops, and it's because innovation isn't even happening at those companies anymore anyway. Like, innovation is the biotech's job at this point.
But think about, again, what you just said, right? From that may be true in the short term, but the hallmark of American ingenuity is to take externalities, this is an externality that might be relevant, take that pressure, in that ecosystem, better models emerge. More efficient drug development will emerge.
Yep.
More efficient distribution mechanisms, more efficient sales and marketing, et cetera, will emerge. And
So you're saying
those
the
who innovate,
shareholders shouldn't actually even be forced to suffer here.
it's always the case as companies have life cycles that shareholders.
Are they really price takers? When they say price takers, I mean that like if the government sets a price and you don't sell to the government for that price, you're probably going to go bankrupt because they're one of the largest buyers. You're going to be non-competitive. You're going to be bankrupt basically.
Succeed and at times suffer.
Yep.
But the innovators come out the back end stronger, and sometimes they're new entrants, right? Which change the game. I mean, that's the hallmark of the free market economy.
So how do we reconcile that, Sam? Because on the one hand, you're saying if drug development and distribution had to become more economical, we are innovative enough as a country to do that. But at the same time, the whole reason we're saying that has to happen is we must have some measure of price control in drugs, which feels like a very anti-American thing.
Yeah, right. I mean, this is what people get into, but there's two issues there, right? First of all,
Okay. Well, that's the rest of the